We are all products of our time. Never perhaps such words collectively meant their truest as the times that we live through now. Never before in living memory of its 187 years of existence has the Bengal Chamber witnessed a world so united in crisis, created not by wars but by the global susceptibility to a virus of pandemic proportions. Yet, your chamber, as an institution and as a business collective, has worked and stood through unprecedented times brought forth by the viral pandemic and the devastating super cyclone, rallying all of us not only towards survival, but equipping us in being ready for life and business in the next normal. Just as Tagore said, if you cry because the sun has gone out of your life, your tears will prevent you from seeing the stars. The need is to adopt sustainability, adapt new measures, and practice the new economics of innovation-led progress to turn over a new leaf. Again, as the poet said, you can't cross the sea merely by standing and staring at the water. And so, we got down to work. The Chamber's yardstick of operations is usually measured by the number, relevance, and contextuality of its programs and activities. If a chest full of 110 events puts the stamp on quantity, the qualitative aspects of our program-led and results-oriented activities are certified by the way they have been received by the audience, professionals, and stakeholders from different geographies attending in impressive numbers in person before the pandemic and virtually since then. The year has hit us hard, and your chamber rose to the occasion.
চেম্বার অফ কমার্স থেকে আজকে 500 বেনিফিশিয়ারির জন্য ট্রিপল, ড্রাই ফ্রুটস, বিস্কিট, এছাড়া সোলার ল্যান্টেন, মেডিসিন, এই সমস্ত জিনিস তারা নিয়ে এসছেন, নিজে হাতে নিয়ে এসে এখানে দিয়েছেন। কিছু জিনিস এই স্পটে দেওয়া হয়েছে, রামগঙ্গায় যে মানুষ যারা এফেক্টেড হয়েছে বাঁধ ভাঙায় বন্যার ফলে সেই মানুষের হাতে তুলে দিয়েছেন। কিছু জিনিস আমার ব্লক অফিসে রাখা আছে, যেটা দূরবর্তী অঞ্চলে আমরা পাঠানোর ব্যবস্থা করবো আগামীকালই। তাদের এই শুভ উদ্যোগের জন্য রামগঙ্গার সমস্ত পাথরপ্রতিমা অঞ্চলের সমস্ত অধিবাসীর পক্ষ থেকে, ব্লক প্রশাসনের পক্ষ থেকে সকলকে ধন্যবাদ।
If this was not enough, the sustained work undertaken during lockdown, supporting our government and the citizens was a part and parcel of our operational existence. As the days rolled into weeks, which spilled into months, your chamber embraced the new normal as the new walk of life. The Bengal Chamber, with its managing committee and the expert committees, under guidance of the past presidents and with overwhelming support from the membership and all stakeholders from near and far, embarked on a journey in which geographical barriers and distances were nullified. Digital and virtual became the realities of the day. This seamless transformation of bringing together people from all corners of the globe, addressing core issues of business, health, social and economic aspects is captured in a montage. What we have experienced is that our pre-pandemic and post-pandemic programs may have been held on different platforms, but the intensity of engagement from participants has only strengthened over these 100 plus activities. The learnings were aplenty.
We will have to work in terms of taxation, in terms of policies for transfers to the poor. And I want to, though I'm saying that right now we cannot be obsessed with those big long-term changes, we have to worry about that very, very quickly, because the level of inequality we have in India is unacceptable and we have to work on that.
I know the NEP talks about it, and I'm totally in favor of having more of our base education, foundational education in Indian languages. And this needs to be, there needs to be a way of making sure that this is done even in elite schools. Otherwise, we'll end up with a two-track country. However, while the theory of this is good, the practice of it, however, needs to be thought about from a very basic perspective, which is that the textbooks and curriculums in Indian languages need to be radically upgraded and updated.
The SWOT analysis, which has been done by the chamber, it mentioned that credit is a major issue. Now, with this growth in the credit, which has been witnessed in the state, this is a problem.
The critical verticals of the economy and business were blended with talk shops and programs on a plethora of subjects. Even the Chamber's signature activities were held for a global audience, with participation climbing into several thousands.
We are moving from a consumer era to a post-consumer era. I mean, we had excesses in our lives, in our behavior, in our spending. But now we are all going to look towards for health and a better balance in what we are going to do.
We are doing certain things in order to be part of the region, but not adequate. It's not making the impact, because a lot of this is G2G, government to government, not enough P2P, people to people, and certainly not enough B2B, business to business. And relationships today in the modern world are less and less about G2G. They are more and more about B2B and P2P.
So we want to have a national depository of knowledge, national practice for each and every item which is being imported in this country.
We are hoping to advance 5 key campaigns to support the reduction of emissions. We want to support a campaign on the transition to clean energy, and India is leading the world in many ways with its 450 gigawatts commitment on solar energy. The switch to clean transport, and I think there are huge opportunities for India to lead this work in this sector, particularly for 2- and 3-wheeled vehicles. A campaign on nature-based solutions to demonstrate how mangroves like Sundarban can not only, protecting mangroves like the Sundarban can not only help protect communities and help them be more resilient to the effects of climate change, but can also help serve as a carbon sink to mitigate climate change itself. Work on adaptation and resilience, which is particularly important in neighbouring Bangladesh, for example, and other low-lying areas prone to flooding. And then underpinning all of that, work on finance.
2 principal focus areas, especially during this time, are people and health. On both, the Chamber has communicated learnings, best practices, and even advisories over and over again to the community at large, going much beyond the immediate business fraternity.
The concept of herd immunity is when you have random spread of a factor and there is 60 to 70% of individuals who are unable to be affected by that factor, that constitutes herd immunity. And if we're all people and the virus infects people, then whether it's a herd in the US or a herd in India, the herd is the herd, right? It's worldwide, but the development and the speed with which immunity develops, that is locally dependent, right? So wherein we in the United States have taken social distancing in some areas to heart, and people have been in their homes for weeks, herd immunity is actually developing very slowly, but in those areas, infection rates are going down. We recognize that eventually we will develop 70% of people who are immune, and that will allow us to save lives, not just because you infect less people per se, but it's because the resources to treat those people become available when they get infected.
Life goes on. Setbacks are always temporary. We fall because we can pick ourselves up again. The Chamber believes that lives and livelihoods are and will be the defining features of this normal that we are living through. In this journey, we have focused as much on addressing the business ecosystem as we have on celebrating life.
আপিস পাড়ার খাবার এই যে ইনিশিয়েটিভটা, এটা আপনারা সকলে দেখতেই পাচ্ছেন প্রায় উৎসবে পরিণত হয়েছে, এবং এটাই আমাদের ইচ্ছে ছিল যে এত ধরনের মানুষ, এত ধরনের খাবার, এত ধরনের রান্নাবান্না প্রত্যেক দিন এরা করে, এবং এদের কোনো স্বীকৃতি নেই সেই অর্থে। হ্যাঁ, আমরা জানি যে আপিস পাড়ায় খুব ভালো খাবার পাওয়া যায়, কিন্তু আজকে সাধারণ মানুষ সবাই বাইরে থেকে এসে সবাই মিলে খাচ্ছে। বেঙ্গল চেম্বার অফ কমার্স থেকে এই ইনিশিয়েটিভটা আমরা নিতে পেরেছি, তার জন্য খুব ভালো লাগছে, এবং সাধারণ মানুষ এইভাবে সাড়া দিয়েছেন, তার জন্য অনেক ধন্যবাদ।
So welcome everybody to the 4th edition of Health Take, presented to you by the Bengal Chamber and Medica Super Specialty Hospital. We have PwC as our knowledge partner, and this program is also presented in association with Woodlands Hospital. So we have with us in the curtain raiser session, Dr. Alok Roy, past president of the Bengal Chamber of Commerce and Industry and chairman Medica Group of Hospitals, Mr. Devi Mukherjee, president the Bengal Chamber of Commerce and Industry and managing director Synergist Energy Private Limited. We are expecting Professor Randeep Guleria, director of AIIMS. Depending on his schedule, he has another meeting. Honorary Brigadier Dr. Arvind Lal Padmashri, executive chairman Dr. Lal Pathlabs Limited, Ms. Anna Roy, advisor DM and A Niti Aayog, Dr. Rupali Basu, Director and CEO, Woodlands Multi-Speciality Hospital Limited, Mr. Arnab Basu, Chairperson, IT Committee of the Bengal Chamber of Commerce and Industry and Managing Partner, East Advisory Leader, PricewaterhouseCoopers Private Limited, Dr. Robin Chakraborty, Chairperson of Health Committee of the Bengal Chamber of Commerce and Industry and Senior Vice Chairman, Cardiology Services and Senior Consultant, Interventional Cardiologist, Medica Super Specialty Hospital. With this, I would request Dr. Alok Roy, past President of the Bengal Chamber and the Chairman of Medica Group of Hospitals, to please deliver his opening remarks and take forward the session.
Thank you, Angana. It's a great pleasure to be here with all of you today on the 4th edition of Health Tech Conference, which has been an annual feature, which we organize along with Bengal Chamber. The purpose and intent of is to get all the stakeholders in healthcare delivery together and discuss what has been happening around in technology, and so update all of us, because we are all caught up in our lives. And we have seen that sometimes the technology slips by. And so just to update all of us, and it's the best example we have seen last year in pandemic. In pandemic, we have realized that technology was our biggest help and biggest savior. Technology came forward to help us in various ways, especially where the infectious rate was so high, R0 was going to 2 and 3. There, the technology became a driving factor in diagnosis. Technology became a driving factor in referrals. Technology became a driving factor in consultation. Telemedicine in last 1 year has been used mostly. The amount of telemedicine technology has been used in last 1 year has not been used for consultation in last 20 years. So that was the volume and proportion where people use technology for coming together and mitigating the disease and providing the relief to the people. Also, the technology was extremely useful in referral consultation, in sending the reports home, in people accessing their reports, the way report was shared across various platforms. So it got clearly established that if we use technology properly, we could help in reducing the time frame in which knowledge gets exchanged, and also save people from getting infected. I think we couldn't have had a more appropriate time to have this 4th edition of Health Technology Conference. And I think I'm glad that we have some of the pioneers in healthcare participating. Dr. Lal, who's the head of Arvind Lal Lab. We have Dr. Guleria. Hopefully he joins us. He had confirmed to join, but last moment, because of the vaccination and all that, a lot of government discussions going on. Hopefully he would be able to join us after Dr. Lal. And we have Dr. Robin and various other senior professionals in healthcare and technology who will be participating in next 2 days. So look forward to have a very, very good interactions for 2 days, and let there be learnings which will all take home. With this, I would invite Mr. Dev Mukherjee, the President of Bengal Chamber of Commerce and Industry, to address this conference. Dev, over to you.
Thank you very much. Thank you very much, Dr. Roy, and a very good afternoon to all of you. I join Dr. Alok Roy in extending a very warm welcome to all the distinguished speakers and a distinguished audience who have joined online to the 4th edition of Health Tech of the Bengal Chamber of Commerce and Industry. This, as Dr. Roy mentioned, is the 4th edition of the Health Tech Conference of the Chamber, along with Medica Group of Hospitals. And I remember going back in time, the passion and the commitment with which Dr. Roy initiated this Health Tech Conference, which I think has picked up significant traction over the last 4 years and has delivered considerable value to all stakeholders in the healthcare space. Health tech, ladies and gentlemen, I think we all need to view in an extended space, so to speak. This extended space where we see the convergence of technology with health, healthcare, lifestyle, and overall well-being of people. It is in this perspective, or in an extended space, that health tech is also the interconnection of health systems computation technologies, smart devices based on IoT, IoT-driven sensors, the internet, the power of the internet, the World Wide Web, the computation analysis techniques, or what in the trade is called data science, use of artificial intelligence, machine learning, and other tools that help in actually making predictions, accurate, precise predictions, and also the communication media, which brings all this together to manage illnesses, to manage health risks, promote good health, and as I said a short while ago, the overall well-being of the people. Technology and innovation, both in terms of adoption and delivery, in a very focused and in a very precise manner, is what technology brings to the table. And that's where technology adds value to healthcare. The challenge, however, remains in accessibility and affordability of healthcare to every strata of the society, and that too for all 3 levels of care, whether it's primary, secondary, or tertiary. And that is where I think we all, as responsible leaders, both from the chamber and from the medical fraternity, along with our technology partners, need to rise up to the challenge and make this aspiration a reality. And I repeat, ladies and gentlemen, it's about accessibility and affordability to deliver healthcare to every strata of the society. We all know, ladies and gentlemen, that in the context of the current COVID pandemic, the global spending in healthcare has been significant, especially by the equity players, the venture capitalists, and I understand in excess of $80 billion have been spent in the healthcare industry. There have been numerous mergers and acquisitions in terms of technology deployment, adoption and deployment, large number of partnerships, and all these activities are gaining significant traction. In the Indian context, you would all agree that on all 3 fronts, whether it is on technology, whether it is on skills, and on scale, we do have a very significant role to play. And the vaccine rollout has also shown that we can play a leadership role. As Dr. Roy rightly mentioned, telemedicine as an effective medium of delivery in the healthcare value chain has proven its worth during these 10 to 12 months of COVID pandemic. Advanced technologies like 3D printing, robotics, wearables, and other smart devices, various digital tools, they are all helping in bringing technology and making delivery of healthcare, as I mentioned, more precise, more accurate, more focused, and more timely. But yes, indeed, there are challenges, but challenges throw up opportunities. And we from the Chamber of Commerce, along with the medical fraternity, our partners from technology business, along with policymakers, we all need to be not just responsible, but responsive to the needs and play a very proactive role going forward. I'm sure we will all benefit from the deliberations over the next 2 days. And from my side and on behalf of Bengal Chamber, I wish every success to this conference. Thank you very much.
Thank you, Dave. It's very kind of you to have addressed the gathering. I would now, I think Professor Guleria is yet to join us. So as soon as he joins, we will include him along the course of the day. May I request Brigadier Dr. Arvind Lal to give his theme address on digital healthcare, vision and reality, global and pan-India perspective. Brigadier Lal.
Thank you very much. First of all, I would like to thank the Bengal Chambers of Commerce and especially Mr. Dev Mukherjee and Ms. Angana Guha Roy, Dr. Alok Roy, Dr. Robin Chatterjee, Dr. Guleria whenever he joins us, Ms. Anna Roy and Dr. Rupali Basu. So ladies and gentlemen, wishing you a very good afternoon and thank you for inviting me here. In the 1980s, the digital revolution began with the computer and the internet, which further led to proliferation of mobile devices, social networking, big data, and computing clouds. As digital technology becomes ubiquitous and accessible to a wider population, it is having a profound impact on the society, industry, and businesses. Despite dramatic improvement in global health over the last few decades, the current model of healthcare delivery is being rendered unsustainable due to the rapidly rising population and greater concerns over restricted public health spending. This holds absolutely true for the Indian healthcare as well. Therefore, maintaining the status quo is not an option. To deliver continued improvements to the world's healthcare will need to be transformed, with digital playing a vital role, which has also been further highlighted by the COVID-19 pandemic, as Anup just told you. So some of the key trends in health include the expansion of remote care solutions like telehealth, adoption of big data, predictive medicine, and artificial intelligence, AI, exponential rise in mobile health adoption, which has tripled over the last 5 years, the use of IoT, Internet of Things, as Mr. Mukherjee had just mentioned to you, an increase of variables such as heart monitors, exercise trackers, etc., and they have quadrupled between 2014 and 2018. Growing investment in blockchain and improved electronic health records. However, telemedicine and artificial intelligence-enabled medical devices and blockchain electronic health records are just a few solid examples of digital transformation in healthcare, which are completely reshaping how healthcare is delivered. So let's talk about digital technology and healthcare now. In presence of stalwarts from the healthcare sector as well as IT sector in this important conclave today, let us take this opportunity to state a simple but concrete vision for digital transformation of healthcare. According to me, the vision should be to enable access to affordable,
and quality healthcare for all through digital solutions that are cost-effective, people-centric, and scalable. India has already embarked on the journey to make digital technology the backbone for a transformed health system with the National Digital Health Mission, or NDHM. Key components of the mission include a health ID, telemedicine, health records, health registry, along with DigiDoctor and e-pharmacy services. India has a very fragmented healthcare providers market consisting of public health facilities, private single doctor clinics, nursing homes, corporate hospitals, and non-profit ones also, with varying adoption rates of digitization and no mechanism for portability of records. There has been a deterrent in the adoption of standardized electronic health records, or EHR, for individual patients. NDH set to change this with unique health IDs being created for all citizens. Adoption of electronic health records will lead to an increase in the quality of care while decreasing costs of healthcare services. Let's talk about the digital health and primary care now. In my view, above all, digital health has a very special role to play in filling the primary care void. This exists in India beyond its tier 2 cities, especially in rural India, where about 70% of our population lives. More than 60% of these people lack access to reliable healthcare, which drives them to seek care from unqualified persons posing as healthcare professionals or travel to far-off cities where healthcare is available. Consequently, on account of catastrophic health expenditures, 55 million people below the poverty line every year. With advancements in digital health, we can bring healthcare closer to where people live, which is otherwise not possible because of limited physical infrastructure and human resources. I am again emphasizing that digital health will be of utmost importance for preventive and promotive health, diagnostic testing, telepathology, teleconsultations, monitoring quality of care, as well as tracking supplies excuse me, and utilization of drugs, diagnostics, and vaccines. I'm happy to share with you that through our philanthropic endeavor, which is Arvind Lal Vandana Lal Foundation, the ALVL Foundation, I and my wife, Dr. Vandana Lal, are partnering with the government of Uttarakhand to equip and run 10 health and wellness centers, HWCs, under Ayushman Bharat program as Smart HWCs to deliver primary care in rural areas of Almora district, Uttarakhand. These Smart HWCs are being digitally enabled to provide essential services like diagnostics, teleconsultations, health IDs, and electronic health records, community-led health and wellness interventions, etc. The 10 Smart HWCs will act as demonstration models for replication across the country. Another NGO that we support is Village Waste Charitable Trust that delivers subsidized healthcare in remote areas in upper reaches of Uttarakhand, again through community engagement and telemedicine at a network of small private clinics. This rural health model has been adopted from your own West Bengal-based Dr. Shwetadhar Saha, an England-returned general surgeon. The model integrates the 3 T's: treatment, training, and technology using a clinical algorithm-based primary healthcare software. So let's talk about the digitization and lab practice. To make you all believe in the transformative power of digital health, let me share with you that my journey of digitizing the lab practice started way back in 1986. I introduced in India the first computerized dedicated lab information management system, or LIMS, and Dr. Gurdial Singh, then recently returned software engineer from USA and ex-Kharagpur, wrote the program in basic language, and the entire program took a space of 20 kilobytes. That was too much for me those days, with which we were able to fully computerize our lab's operations. This was a pivotal moment in diagnostics in India. Then in 1999, we installed the world's most prestigious Triple-G LIMS, known as Ultra, for the first time in India. It gave us a true bidirectional interface, provided connectivity between collection centers, and became the backbone of future connectivity between other labs and hospital labs. Though the software was in Unix,
excuse me, a language which was not very user-friendly, and the database was in Unified 2000, its sturdiness was truly amazing. So now let me explain to you what we brought to the country at that time. So on the left-hand side, we have this lab in Tripura, which is a public-private partnership for a long time. And the bar-coded Vacutainer containing the patient's serum gets or hits the biochemistry analyzer. And the barcode is read, in which the ID of the patient is mentioned. It is transmitted to our server in Delhi, which is 2,800 kilometers away, via the INSAT 3C. And the server in Delhi, after having received the lab number, has already been updated at the time of registration of the patient, namely with his name, number, etc. But most importantly, the test order. The test order is sent back to the analyzer in Tripura via the INSAT 3C, and each jump or each cycle takes 8 milliseconds. And gentlemen, we brought this into the world for the first time in 1999. It was not Tripura at that time, it was Kanpur. So today, the backbone of our business is the IT platform, a complete revamp of which was carried out in 2012 when we commissioned an IBM-designed and IBM-operated data center at our Rohini reference lab. We were the first diagnostic lab in India to install a very sophisticated LIMS called Star LIMS 10.5 version from Abbott. 2014 onwards, we kept increasing our digital health adoption pace to serve the consumers in the best possible manner. This includes developing the mobile applications for customers to register and schedule sample collection. The same app is also used by on-field phlebotomists. A chat bot on our website to answer all report-related queries is there. An EMRF, which is Material Requisition Form Portal project, was implemented to overcome issues of material management. Deploying equipment like the Philips ultra-fast scanner to digitize our histopathology samples and obtain high-quality clinical diagnostic images, hundreds of kilometers or thousands of kilometers away. By the way, the #1 histopathology testing lab in the world, and we test more than 1,250 biopsies every day. Then totally automating the lab process, where lab instruments are integrated with LIMS that tracks specimens and workflows, aggregates data, and ensures lab operations are compliant with various standards and regulations amongst several other initiatives. And I would say that this is a continuous process. About the public-private collaboration. In India, we have witnessed that the private healthcare sector has a large acceptance and appetite for adoption of disruptive, innovative products and processes. Therefore, it is imperative for the government to partner with the private sector to draw from their learnings and implement digital health in India. Earlier this week, I was a part of a webinar organized by Ministry of Health and Family Welfare, where the Prime Minister himself addressed us and said that the center was looking at the public-private partnership model to upgrade India's healthcare infrastructure. He mentioned it specifically in context of the National Digital Health Mission, maintaining digital health records of citizens and other cutting-edge technologies and creation of public health laboratories. While technological development moves quickly, the same is not always true of public policy. We should not let this happen to digital transformation of health system, especially at this time when there is a political will and commitment from the Prime Minister himself. Let's talk about the key challenges. Although healthcare, health has the potential to be changed profoundly by digital technology, and this is now a national priority, the challenges faced by healthcare consumers, health professionals, providers, industry, and the government cannot be underestimated. Through the deliberations of this two-day conclave, I hope the experts can come up with strategies to overcome the 5 key challenges to go truly digital. And the first challenge, in my opinion, ladies and gentlemen, is the last mile connectivity. Unavailability of affordable high-speed communications services, the digital divide, as I would call it, is one of the greatest challenges for implementing digital health solutions in rural areas and many others too. And by the way, what I showed you, the the satellite model is a costly model. While the government's BharatNet project aimed at connecting 2.5 lakh gram panchayats has made 1.5 lakh gram panchayats at the headquarter level, this connection needs to be extended up to health facilities in the villages. New advances like Elon Musk's project Starlink are worth keeping an eye on. Starlink aims to provide internet connectivity across the world via a network of 12,000 private satellites orbiting overhead. It has already launched more than 1,000 satellites and announced to provide a speed of up to 300 Mbps. I'm not sure whether hundreds of these satellites were launched from our INSAT rockets, ISRO rockets. In absence of reliable internet connectivity, the digital health agenda cannot be realized in rural India. You can say goodbye to it. Cultural barriers in the adoption of digital health. Due to a disconnect between tech developers and the customers, both healthcare professionals and patients, adoption of digital health solutions has been rather slow. Along with making healthcare professionals a part of the product development, developing their digital skills is critical to successful adoption in practice. Similarly, for patients, creating awareness about digitally managing their health is crucial. But how do we do this effectively? Let's talk about giving some incentives to healthcare providers. Migrating from analog to digital health is an expensive affair. Though it reaps cost benefits over the mid to long term, the upfront cost is high and even unaffordable by many healthcare providers. As Indian healthcare is dominated by usually single doctor clinics and small standalone doctor-owned hospitals and nursing homes, substantial incentives have to be offered to provide providers to help them switch to digital health solutions. Then let's talk about the personal data protection. Absence of a legal framework for data protection in India has increased the risks related to digitization. The pending draft Personal Data Protection Bill considers health data as sensitive personal data. For example, no patient would like the world to know that he went for an HIV test, and no lady would like it to be known that she went for a pregnancy test to, say, Roy and Trivedi Labs. Even though new technologies and government initiatives to improve cybersecurity are underway, there is no mechanism to protect consumers as well as healthcare providers in case of any accidental breach or criminal attacks, as we faced one recently. And the last challenge, in my opinion, is the interoperability and overcoming the silo effect. Lack of interoperability continues to be a stumbling block in the development of digitally enabled ecosystem. The transformation cannot happen merely by each one of us adopting digital technologies. Unless the data and records we generate can be exaggerated, can be created, exchanged, patient-centric healthcare cannot be delivered. So in conclusion, ladies and gentlemen, I would like to emphasize that healthcare industry can no longer afford to be sluggish on uptake of digital health. In collaboration with governments, health tech developers, healthcare providers, IT industries and consumer, we shall turn our vision for digital health into a reality. Thank you very much.
Thank you, Dr. Lal. It was so well spoken about you, and of course, the cost effectiveness and the scalability are two paramount factors. And thank you for elucidating it so well. With this, we move on to our next speaker of the day. May we request Dr. Rupali Basu, Director and CEO of Woodlands Multispecialty Hospital Limited, to address on leadership in healthcare in digital age. Rupali, over to you. Rupali, you are muted.
Mute yourself again.
Rupali's microphone system is needs to be addressed.
She was audible for a moment.
Angana, any information about Professor Guleria?
No, his office has not yet informed us.
Making a lot of sound, I see. Is it making a lot of sound? I think I'll have to join again.
Like to join from your phone?
Is it better now? Can you hear me?
Yes, clear.
It is perfect now. Yeah.
So sorry about that. Okay, so the leadership when particularly when we are talking about health tech, I thought that it's important to also talk about the leadership which is at the most challenging role in today's age. And what have we done? We have done past 1 year. We have really looked at. We have discovered a new disease. We have looked into how we have to diagnose the disease. What are the things that we need to, created infrastructure, created equipments, HFNOs and ECMOs, and then we actually, invented medicines, and now we are gone into prevention and, vaccination. So we have within this 1 year, I think the leadership at the healthcare organizations at all levels have been really challenged, really pushed us in every way. And we are, I personally think that whatever the fancy things that we talk about, they are not only fancy, but they're all the right things that we are talking about on getting digitized. And we are into that digital world, but we are still not actually in the digital world. It is still like the way we do CWIP, it is DWIP, digital world in progress. So it is still, we have to still do a lot of manual work. So naturally, in this kind of, in progress situation, the leadership which is constantly is been bombarded with, what we are supposed to do. And that's how I think that, that it is important to talk about leadership. And what I think what we have to start with, if we have to really start with two areas. One is that our own individual, area, that what do I do as individual leaders when we are chosen, and one is that external influences on our leadership, how that is impacting our leadership style, leadership work. So the leadership is, I think the start off with is that we have to have a digital mind. In this digital world, unless you have a digital mind, it is very difficult to really take on the leadership. And that's why that's the start point. Once you have a digital mind, I think we need to move on. What is this digital mind all about? It is all about talking, learning about the new things, the knowledge, the innovation, the research orientedness. Unless you have that, knowledge hungry mind, unless you are, you are in the huge knowledge which is out there for all of us, we are really not ready to take on to the world today. Be it pandemic year, or we will end the pandemic at some point and get into our normal life, later. So whatever the situation is, I think this research-oriented mind, digital mind, knowledge-seeking mind is very vital. The moment you have that, then you are ready to do the next steps. Next steps is all about, being analytical. in the digital age, everything is there on your dashboards, on your reports, on the people that are working in the healthcare situations. Healthcares are, we all know that there are all service industry, and different kinds of people are there to help you in getting the services through. So you need to be in touch with your people in different ways of connectivity, be it using your WhatsApp messages, or use your emails, or use different kinds of reports, different kinds of communication, video clips, all kinds of things are happening these days to be connected with your team. And it is again has become a world of 24/7. You are actually working 24/7, 365 days. So you are actually connected, and you are analyzing the information that is coming to you all the time. So 24/7, 365 days. So naturally, this analytical mind is very vital. But at the same time, and this will give you the maximum decision making in leadership. The more analysis you do, the more information you have. And if you have a research-oriented mind, and then you have the analytical mind, then you kind of do your decision-making pretty well. But at the same time, at the healthcare sector, because it is related to people and related to service, we have to be also charismatic. We also be very, very people-friendly, and very, very on-the-job kind of leadership. A leader which can go down to the floor level and be talk to a housekeeping boy easily, and go around in your wards and talk to your nurses, know the names of your staff, and relate to them. The more at the ground level, at the floor level, is very important. So the digital age tells you to be analytical and be behind the computer, but in the healthcare scenario, actually you need to be out on the field. So that combination of analytical knowledge and be on the field is actually gives you a good leader. It has to be a combination of the charisma and your personality, and a combination of your knowledge. I think that's, if you combine the two, the best leadership and best decision making happens 24/7, 365 days. That's what I think is in your own personal area you need to work on. But then your leadership is also being bombarded with a lot of information from outside. Look at the way the private sectors where we belong, or for that matter, public sector where the government, other doctors, and in the whole sector is either private or government, and there are in between some more in quasi-government and quasi-private organizations. That is what the whole healthcare sector is all about. And all these areas, there are a lot of influences from outside, and these influences actually hamper your leadership status. Leadership, it challenges your leadership all the time, because you want to do it in a certain way with your knowledge, with your analysis, with your data, with your charisma, but then you are being bombarded with things which are coming from outside, which is not really under your control. And how much we get influenced by that, how much? It's a lot. You get influenced, and those influences actually influences your everything. As a leader, you are supposed to be in touch with your people. You are supposed to deliver the care. You are supposed to be supposed to deliver the financial requirement of the company or the organization that you are working with. So there is a lot of requirement. And those requirements and those, the work that you are supposed to do gets hampered, gets influenced by all this. And we know how much they can change. Today we are even looking at that if the entire private sector, the kind of capping of the prices of your products coming in is actually, you don't even know that the investments that you're doing, what you're going to get your revenue out of your investments, because there's so much of influence happening, and so much of things which are external to the work that you do. So we need to be, the leadership has to be naturally then careful of those influences coming towards you. So we need to be very, very open, very again analytical, and take down those inputs from outside, and make sure again a balance, balance of the best of whatever the influences from outside or the knowledge that you get, and you deliver. Your body language, your the way you talk, the languages that you use, the thought process that you have, everything actually counts. Everything counts. So I think that these influences are going to increase more and more, and the science moves beyond all of us. Science will keep moving. There'll be new diseases will come, new inventions will happen, new equipments will come, science will move. Science is dynamic and it will move. So in spite of whoever tells you to do what, your science will keep on moving. So with this scenario, we need to scientific. We are all healthcare sector is a pure scientific sector. So if we are driven by science, so we need to kind of have the scientific mind, scientific way of doing things, and at the same time, your digitization, influences from outside, preparation of your own character, your own charisma, your own leadership is what we need to do. I think it's a lot to ask for the leadership, but at the same time, I will end up saying that we don't have actually ways to create good leaders in our country. I don't think we have in our medical profession, when the medical CEOs they are not taught management at all. We are healthcare management professionals, so I've been trained in different organizations, different universities, as good as a Harvard too. So we are trained and we have been into the field for a long time. So, but then there are, as I see around us, it is still a long way that the healthcare leadership is also being prepared to take these challenges and be successful leaders going ahead. So we need to maybe create a CEO's council, or somewhere where we map maybe we can start with the city and the country and maybe the several other countries, and then kind of make sure that all the CEOs who run healthcare organizations or all the healthcare leaders do think in the same way, do eat in the same way, do things in the same way. And that's how I think certain things are very constant and certain things we cannot differ. It should continue in the same way. So if we are together in those ways, our companies may be different, our logos may be different, our people may be different, but there are certain things which are very constant, and we must agree to those things, because science doesn't change. 1 + 1 is always 2. So with those words, I think there's a lot of challenge to the healthcare leadership, but at the same time, we have shown how we have taken up the pandemic in such a wonderful way. We have not messed up with care. We have not messed up in diagnosing. We have not messed up in treatment. I think the large responsibility which is given to us, and we will be also vaccinating, and prevention is also on the way. So we will be doing our job well. And I think the biggest example there is the leadership and protocol-based care. We have worked on, from the government of India to the state governments to all the healthcare providers. We have worked together in the same mind that we have to, the common enemy is the COVID-19, and we've moved ahead. And that's how I think we have to move ahead with all our diseases, the 10,000 plus diseases and 4,000 plus activities that we do in our hospitals. With that promise and with that hope, I will conclude my my little talk today. And thank you very much, Bengal Chamber. Thank you, Dev. Thank you, Rovinda. Thank you, Alok. Thank you, Dr. Lal. All of you who are here, Mr. Roy and Dr. Basu, all of you, Amuna, all of you. Thank you very much for having me. Thank you.
Dr. Pali, it was very kind of you. And of course, I agree fully that the way the private stakeholders in healthcare rose to the occasion of pandemic and got together, and along with the government, we defeated the disease to a reasonable extent. And the way government has appreciated 2 days back, where Dr. Lal also referred to, where the Prime Minister addressed all the healthcare stakeholders along with the government officials, and very categorically emphasize the role of a private healthcare provider is obviously remarkable, especially when we were used to being criticized, where the Prime Minister himself on a national forum is appreciating the role we all have played. So it reestablishes that the healthcare, whether it belongs to the private or belongs to the government, it belongs to the people. At the end of the day, it belongs to the people. And leadership is a challenging issue and a very important issue across the globe, in our country too, especially in the pandemic. So with this, we are very happy to have with us Ms. Anna Roy, Advisor DMNA Niti Aayog, and welcome to this forum, ma'am. This is our fourth forum of Health Tech Conference, which is organized by Bengal Chamber of Commerce and Medica Super Specialty Hospital and all the hospitals of Eastern India. The intent of organizing this conference is that we share whatever is happening in digital health, digital area to the healthcare arena. And your address would be very useful for us to understand the government and your viewpoint in that direction. With this, we invite you to deliver an address on Government of India's vision on digital healthcare. Ms. Anna Roy.
Thank you, Dr. Roy. So I must be the only one who is not a medical doctor on this panel, I think. And I have been heading the Frontier Technology vertical in Niti Aayog for the past 3 years. By training, I'm an economist, so I bring in a whole lot of stuff to the table. So, we are living in this era, what has come to be known as the Industrial Revolution 4.2. Now, what is it? Basically, I would first of all like to refer to the budget, this year's budget, which put the stress on wellness, nutrition and wellness. So that, shows the thinking, the direction in which the government is going. So it is more towards prevention. And through prevention and better health services, better health of the population. So the shift is now on prevention. And when I talk about Industry 4.0, this bouquet of technology which comes under this fourth industrial revolution is something which really provides us the tech opportunities to move to a space where we not only, have a more strengthened preventive mechanism, but we also, are able to overcome some of the challenges which the country has been facing of access barrier, of lack of resources in the med space, and that's why I would like to emphasize on this technology and speak a little bit about this technology and highlight the potential of this technology, and then at the end talk about what Niti Aayog is doing and look for collaborations, because we all collaborate in Niti Aayog with various stakeholders, and private healthcare establishments are one of the areas, one of the stakeholders with whom we work closely. So this technology is typically cyber physical, which brings digital to our physical world. And here what happens that you are able to like the COVID so well the COVID pandemic showed how despite lockdown, despite social distancing, we were able to achieve a whole lot of stuff. And that is because of the digital advancements in the country. We could all work from home. We moved on over to the telemedicine part, and several things were done digitally, which earlier, though the infrastructure and other resources were available, but the push came because of the pandemic. So that is the potential, and let me tell you, we are just scratching the top. The potential is much more immense than what we see today. Niti Aayog came out with a strategy document on AI, artificial intelligence, which is part of the industrial IR 4.0, along with drones and quantum computing and various other technologies. And artificial intelligence is a means which allows us for kind of, supplementing what the medical profession is also doing. There is always a apprehension whether this will replace humans. Now, in my view, while this is presently a pedantic kind of a debate, and I really am not a future teller, so I don't know what will happen going forward. But while some automated jobs will get, taken over, I still feel this technology will supplement and augment the capacity of the human beings. It will not replace the human beings. That is my personal view. Of course, people may disagree, and I feel that we need to push this, because this technology is something which will help us in meeting our various challenges. What are the enablers for this technology? First, you need to have the data, because data is something which will help you in bringing out the tools, and you need to have the huge compute. So artificial intelligence is not something which is a new technology. It was there in the 60s, 70s, but the recent advancements in storing large amounts of data and advancement in compute infrastructure, which allows us to do a lot of big data analysis, that is what has brought the AI to the forefront. And health sector is one of the main sectors where this can really be a game changer. Besides education, agriculture, several other sectors, financial sector also. This was understood early on, and the national health policy and the national health stack and the national digital health mission subsequently really embarks on this particular philosophy, where you are trying to create this registry of patients, which will help us in developing this database. So, like we have experienced in the digital payment space, what the India Stack did, similarly we hope going forward the National Digital Health Mission and the National Health Stack will help us achieve similar advancements in the health space, because that is the way forward in which we can really leverage this technology. COVID, the way my previous speaker spoke about the COVID vaccination and how we have dealt with COVID. So, COVID vaccination, where, huge amount of in the phase 1, it was given identification, verification of the right set of people. And now we are moving to phase 2, where we are collaborating with the private sector. There also we are leveraging the technology. So all that is possible because of the India Stack, which was developed earlier on. Ours is the country where 1.3 billion have a unique ID. So, with unique ID, with storing documents in the cloud where it can be accessed without going physical, with e-signature, various such technology interventions have allowed us to do all these interventions, and also during the COVID time, be it the Arogya Setu or be it any of the other interventions which helped us manage the pandemic. So I think one of the important issues we need to realize is that understanding the potential that this technology brings in. Niti Aayog comes out with policy papers. We have come out with the strategy document. We have come out with several other papers, but in parallel, we also implement some pilot projects. I would briefly refer to some of these pilot projects, which will, highlight the scope of this technology. Delhi AIIMS, in collaboration with a West Bengal-based startup, has come out with a integrated medical device, which is actually a chair where if a patient sits on the chair within 15 to 20 minutes, around 41 parameters are measured. And those parameters, the data is directly sent to the cloud. And from the cloud, it can be accessed by any remote district hospital or any metro hospital, and can be reviewed by experts. So you do not need to have specialists sitting in a small town or in a remote area, but people in those towns can have access to the expert advice of these experts. So that is one of the very important means of overcoming the access barrier. we can follow a hub and spoke kind of a model. And you collect the data. On top of the data, then you are able to also kind of develop tools which will help you in prediction in a more automated manner, where you do not need, say, in diabetic retinopathy, you do not need an ophthalmologist, a trained ophthalmologist to sit in a small village. You can just have these scanners where the images are scanned, images are loaded, and the images are studied by the AI tool, and it can be seen by experts. So one phase where access is not there to the specialist, that phase can be overcome by having these automated tools. And it is very important that all stakeholders get together towards developing these tools, which helps complement the work done by our healthcare professionals. So this way we not only overcome the access issues in remote areas, but we also ensure that those people who are really daily wages or who really do not have the luxury of taking leave and going to hospitals, their time is also saved. And we go over to the preventive mode where, early on these diseases are detected, and through a hub and spoke, they can be kind of referred. So these are various models we are presently working on. We are working under the guidance of Dr. Vinod Paul. We are, coming out with a vision document for health interventions in the, technology interventions in the health sector. And there we are looking at all these issues. The other important piece is the data piece. Now, how do you deal with the data? Personalized data, especially in the health sector, privacy is a big concern. So we are looking at various models on how to overcome it. Technology can come to our rescue. We have data sharing, architectures already being proposed, which are consent based. And as we had earlier, argued in our strategy document, that through knowledge sharing will also something which can be dealt with, and in a transparent manner. If we deal with it, the data can be made available, which will really go a long way for our the Atmanirbhar movement, where our startups are given an opportunity to work on it and come out with new tools which can assist our health fraternity. So that is the second part of it. Then we come to the adoption. Now we are in UP's Bharej doing a project on decision support. Presently, what happens that there is a protocol, so Asha worker, Anganwadi worker go through a list and kind of fill it up in the register. We are trying to have a technology intervention there, wherein NHS kind of a system, there they have a decision support. So through a tablet, which is preloaded programs are there. The work, the human errors get kind of addressed, and the reliability of the work done by these field level workers becomes more reliable. So that is another pilot project which we are implementing. With the TMC Mumbai, Tata Memorial Center Mumbai, and IIT Bombay, we are working on developing a biobank for cancer, which is expected to be the biggest cancer biobank, and will go a long way in promoting research in this field. So that is another big project which we have embarked on. One of the most latest technologies which is still being validated, I would like to highlight. In our experience, we found that in neonatal care, in many instances, the Asha worker or the Anganwadi worker will just, routinely note down the height and weight of the infants. To overcome that problem, with the Vadhwani AI Center, a new technology using computer vision and AI is being developed, where by taking a mobile picture of the infant and putting it on the cloud through the AI tool, the height and weight can be assessed, and that technology is being validated. So through all these interventions, these are small interventions, but they can really kind of make our health providers, the services more robust. And we need to work in collaboration. That is the message which I am bringing here. We work closely with Apollo and GSK to develop a properly tried out mechanism of pharmacy, a pharma supply chain using blockchain on ensuring that the right medicines are going, the cold chain is not being breached. So these are several things which we try and also try to find out what could be the challenges on the ground by doing various pilot projects. What are the governance challenges? But this is not something either the government can do on its own, or the industry can do, or the academia can do on its own. Collaboration is the buzzword here. And I bring this message to this Chamber of Commerce that we need to spread awareness about this, about the frontier technologies. Now there is no difference between a technologist and a domain expert. Today, doctors talk technology. Doctors are aware of technology. In our biobank project, doctors know what they want, so that a wall between a computer scientist and a doctor is really kind of disappearing. They need to work together. And obviously, government, academia, and industry need to come together, because A, development has to be done. B, on the deployment part, government will be the biggest adopter. So with that, I end my intervention and look forward to working with many of you in the times to come. Thank you very much.
Thank you, Mr. Roy. It was a very nice deliberation, and thank you very much for being part of it. With this, Angana, and if we do not have any information about Professor Guleria, then we'll move on with our release of the thought paper.
Yes, sir. Professor Guleria's meeting is still on, so we move on with our release of the thought paper. Okay, so
Mr. Arnab Basu, Chairperson of IT Committee, the Bengal Chamber of Commerce, and he's a managing partner, East Advisory Leader, Rice PwC. And every year he's been associated with us. We have partnered together on the journey of health tech in the Eastern India. So with this, I would request him to release a thought paper on transformation of patient journey in a virtual health care setup in the new normal.
And since it is a virtual program, and every year we do a formal release of this paper, so we would like to have a virtual release in this virtual forum. So I would request the tech team at the chamber to please play the video. PwC has been the knowledge partner for Health Tech presented by the Bengal Chamber of Commerce and Industry and Medica Super Specialty Hospital. This year as well, they have joined this endeavor, and a thought paper has been authored by them on transformation of the patient journey in a virtual healthcare setup in the new normal. This thought paper is being released formally in today's forum. The link would be available in the Chamber's website, which would be shared with you subsequently. So over to Mr. Basu. I will share where the link is uploaded in the Chamber's website, but would like to hear from Mr. Basu first.
Thank you. Thank you, Angana, and thank you, Dr. Roy. So it's a pleasure to be part of this initiative every year. And the team has worked on this paper. We do hope that some ideas would come out which can be adopted. The paper really this year we were thinking of, what to focus on, because every year we keep focusing on different items. So this year, I think the paper really aims to identify how the pandemic has disrupted the way healthcare services were being provided, and how, the changes across the patient life cycle, and how healthcare is being provided remotely, how that is changing on a permanent basis. And I think whether it's in terms of, current limitations of supply demand, it helps the country in overcoming that challenge. There's a fair amount of revenue leakage in post-operative care. Also a fair amount of benefit in terms of, saving time for patients. Also the, the response of the providers to the, pandemic brought us many ideas in terms of cost-saving opportunities. So it's not just the time, but also the cost. And remote care, I think many of the, providers here would appreciate that it has been taken with the right spirit, I would say, by the consumers. And most of the consumers we have spoken to in our primary research who have used the remote care facilities which are being provided, they have been pretty happy with it. Technology obviously makes it much easier for them to adopt it. And it's not just about the tier 2, tier 3 cities, even in the metros, we've seen a lot of adoption of that. I think the other one which we heard Anna Roy talk about was around the, the health data. And again, a large part of this patient life cycle and remote care can be offered if we have the right amount of data, and we prioritize the health data amalgamation in the right way, in terms of having the right legislations, having the right level of security, taking the right consent from the patients, so that a single source of truth is there in the ecosystem which can be used. And I think with all these possibilities, the paper also talks about some of the barriers that the industry is currently trying to overcome. And we have tried to categorize these barriers into four domains: the technical difficulties, the behavioral changes which are required, the systemic changes which are more around the legal or the regulatory, and the financial, and how each of these would have to be tackled separately. And also, I think the other thing which we have seen is that if you look at the overall ecosystem, the different stakeholders need to come very closely work with each other to, make this a reality, whether it is the government or the actual healthcare providers, the digital startup ecosystem, and also the IT vendors. So from our interactions with the, four groups, we do think that the right intent is there and the time is very right now in terms of moving to this. And quite a few of the challenges are being looked in by the different stakeholders on a real-time basis. We heard some of it today as well. So we are very hopeful that it would bring in a new way of approaching healthcare in a very supply-demand mismatched environment. And as we move into the new normal, we hope that this will be the way forward. Thank you. Back to you, Dr. Roy.
Thank you, Arnab. Thank you. It was a great effort, Arnab. Like every year, you put up a thought paper, and I'm sure we have enjoyed all your previous thought papers. This one we would enjoy too. And before I request Professor Robin, may I ask Angana if there are any questions from the panelists, so we can take up those questions. I know Dr. Lal and Mr. Roy have been waiting there for quite some time. If there are any questions, but I have a question to ask both to Dr. Lal and Mr. Roy. Sir, Dr. Lal, my first question is to you. That you showed that since 2014 you have been working on accessions and report delivery and all that using the ISRO satellites and all that. So that was phenomenal, and what you are doing as a ALVL also is phenomenal, that you are spending your trust money in developing the various connectivity. Can you elaborate on these 2 points a little bit more for us to understand?
Certainly, thank you. And the first question about the using of the INSAT 3C took place as early in year 1999 and 2000. And the simple reason why we needed it was, at that point of time, it was a lab in Kanpur which we had to get connected with us. And the same software, if you remember, we were using at that time an Australian software by the name of Ultra, by a company by the name of Triple G. So even the connectivity by landline was not good, and land telephone lines. In Australia, they had no problem, and that's how they came to us. So we had to use an innovation, and this was INSAT 3C transponder was given to us by a company known as Hughes Escorts. And Hughes is an aviation space company, and Escorts was into telecom at that time. And so they provided us, and it worked very well. And the connectivity was there, I think, more than 90 or 95% time. And it was slightly expensive even at that time. And of course, now once you've got the cables, the optical fiber cable, well, things will change. But as I said, the last mile connectivity, and there's a difference between the slip between the cup and the lift. So that is not yet achieved. The second thing which you were asking me was about how we our initial. It's very simple, Alok. It was majboori, and we had about 80 or 90 patients per day, and their reports had to be typed. And two typists were bang on the typewriter, starting from 12 o'clock in the morning. And my Hanuman Road, many people know, was have been to that lab. People who are slightly old. So the day one, typist would not report for duty, hell would break loose. And we had to write the report of a patient as normal value, his test value. Then below that, we had to write every time blood sugar fasting normal is between 80 to 120 milligram per deciliter, etc. And then we did not know where one sample went, So it solved a lot of problems. But, if you're a pioneer in these kind of things, a lot of equipment, a lot of new tests which we introduced. So the good part is that after that, you get the videos. But at that point of time, you really used to feel that you should run away from here some days, but things were just not happening. So with perseverance and, time factor, IT was accepted very well. I remember when I was a young doctor, the highest export of India, export earning was about 6,000 crores of the diamond industry. Maybe Arnab or they would, like to comment on this and just see where the IT industry has gone now. So I think with passage of time and with the Indian so-called fertile, mathematical mind, which is good at numbers and is logical, or so to say, at least in IT, so has, taken us, many strides forward. Thank you.
Thank you, sir. I still remember that when we started telemedicine first time in 2000, we borrowed the satellite from the ISRO, and it used to be a hell of a job. Number one. Number two, then the government came up with a telephone network which DOT was running, some digital fiber which used to connect, and once in a while somebody in Bihar will cut it on the roadside, and all our telemedicine will go for a toss. In 2000, we connected with the Tripura Sundari Hospital, an extreme remote corner of Tripura, where South Tripura, where we are doing the CCU management. Is to be today, all this can be done on a WhatsApp, video WhatsApp. So the technology has really moved. And that is what brings my next question to Ms. Anna Roy, that with this challenge of vaccination, which is looming very large in our country, and that's the only way we can eliminate or at least stop the disease progress at this point of time. And we'd like to hear a little specifically from you, if it is possible for you, to talk about that how the digital role which we are planning for this particular aspect of it.
the digital role basically is on identification of the beneficiaries, because obviously due to a demand supply mismatch, everybody cannot be administered. So the digital role comes through that mobile app which was used for the phase 1. And now on first the version will be launched for phase 2, and we are looking forward to that launch. So basically what it will do is to, I think, I'm not really qualified, I'm not working in the COVID space, but what I am aware is that it will help in identification and ensuring that, it goes to the right person. Because in a country so diverse like ours, and which is so huge length and breadth, it is really a mind-boggling, exercise to say that, okay, this bucket will get it and this will not. And with all the jugaad in this country, if our technology helps us in achieving the vision which the government has set, I think it is really commendable. Because yesterday I was hearing about US, somebody was saying about New York, that outsiders in New York have got the vaccination, but the residents of New York, have not got it to that extent. So we are not, facing that problem. I think in our case, it is going very systematically, and it is because we have this India stack. We have this unique ID for each individual. Otherwise, how do you track it digitally? So we have the backbone already with us, and which has seen us in so many other sectors, and that is what is, I think, bearing us out in this COVID vaccine thing also.
Well, look, may I have a question? Just a simple question to ask, ma'am.
I would come back to Rupali.
Okay.
I just want to comment on that, then I'll ask you. Okay, you go ahead, Rupali. Go ahead. You are the
small question. I was just, because ma'am is asking about, Miss Anna Roy ma'am is talking about using the, the digital ID, but actually for vaccination, we are not using the Aadhaar card. And I don't know why 130 crore population do have Aadhaar card are not using it. We are using PAN card of people, and there are many people who don't have a PAN card, and we are using voters ID card. Why we are not using Aadhaar card for vaccination registration? It's a huge activity that we are doing at the ground level, and registration of vaccination is not happening with Aadhaar card.
Actually, it is happening both with Aadhaar card and voter card. Both are being used. Somewhere the Aadhaar cards are not functioning, especially the COVID has not taken it. That's a technical question. We can go that
technical question. Yeah, okay.
But I think, Ms. Roy, the reason why I was asking this question, the technology is very important, not for us for the ease of operation, also to ensure that operation, whatever is intended for, is done appropriately. One of the biggest criticism of private stakeholders in getting into vaccination plan is that many of our CEOs and hospital heads have given vaccination to people who don't deserve it or who are not the part of it initially. That has been noted by the government, and government was very reluctant to go ahead if not properly. That was one of the problem which they had in their mind throughout. And I think a time has come for all our private stakeholders, CEOs, to be very, very ethical and very, very identify with the need of the time, not with the need of your employers or not with the need of your shareholders. This is a time when you need to identify with the country and ensure that what country's priority is your priority. Sometimes those who write our paycheck, we get carried away by them and do favors. And it's known to everybody. Because anybody who has been injected, he has spoken in some forum here and there, and that has been captured, and government knows it fully. Unfortunately, the problem is so huge that we have no option but to go on, and there's no option but to get together and eliminate it by working together. So with this, I think we had a great show. I would request Professor Robin Chakravarty for his concluding remarks.
Thank you, Dr. Roy. I think it was a great session, curtain raiser session of Health Tech 2021. I really enjoyed every speaker's presentation, from our president, Mr. Dev Mukherjee, of course, Dr. Roy. Your conduction of the whole session was great. And Dr. Arvind Lal, you are simply unique, particularly your message about digital doctor, about digital health, particularly talking about preventive and promotive health, was very much pertinent to this particular session. I also would have looked forward to have some highlight about, today we talk about more of a prediction of the disease. So from preventive medicine to curative medicine, we're actually moving towards predictive medicine to corrective medicine. How the digital technology can also talk about predictive medicine and corrective medicine. Your 3T technology was highly commendable for this particular session. I really enjoyed the 5 key challenges that you highlighted in your presentation. And Rupali's presentation, Dr. Rupali Basu's presentation on healthcare leadership was unique, and she had that charisma to take the leadership at ground level, which she proved a number of times, particularly even at the housekeeping level, which is worth remembering. And today, with the digital technology having in hand, you can actually take the leadership of healthcare to at every level of the hospital and every level of the healthcare areas, healthcare space. Mrs. Anna Rai's presentation was unique, particularly about the pilot project and about the integrated medical device was excellent. I really enjoyed when you mentioned about the person sitting on a chair, and then all the data is being captured from there and then being communicated to a far field areas to the doctors and clinicians, and accordingly the therapy or the management plan can be adopted. The only question I have, that today we know that a person can sit on a kiosk, a lot of data can be collected that can be communicated to the clinician, and in return they can advise. But we do not have any legal permission for those advice. So maybe from the Niti Aayog committee, if some measures can be taken up. I remember my younger days when I used to sort of travel by train. In Howrah station, you stand on a kiosk and you get your weight and your kind of calculated height and weight, and at the same time your fortune. But that did not have any validation. So when you have such kind of data being collected by kiosk and then application, it has to be validated by some nationally recognized body, and that has to be approved by the National Medical Council, so that there cannot be any legal step taken against the clinician or against the diagnostic centers or the hospital against those kind of practice. And that is very important. And finally, Mr. Arnab Basu's presentation is really excellent. And as an IT committee, I really impressed with in a very simple format. Sort of, he talked about the thought paper, particularly the transformation of patient's journey in today's in the digital technology space, particularly in relation to healthcare. It is a wonderful session. Thank you, every speaker. And we're looking forward to having you all in the next forthcoming session in Health Tech, and perhaps much more such session from the Health Committee of Bengal Chamber of Commerce and Industry. Thank you very much.
Thank you. Angana, I hope you have shared the link with everybody.
Yes, we will email the link to all registered participants, and we will also post it in all chambers' social media handle in some time.
Okay, over to you.
Yeah. So thank you, everybody. So we conclude the curtain raiser where we stand in digital healthcare of the 4th edition of Health Tech. So we will move on to the next session, which is Trends in Health Tech, which would be chaired by Mr. Arnab Basu. He is there in this session, and where we will have the overview of the thought paper by Mr. Shantan Chatterjee, PwC Consulting Director, and we'll be joined by Dr. Sujoy Kaur, Chief Medical Information Officer and Vice President at Apollo Hospitals, Mr. Klaus F. Nilsson, Global Digital Health and Virtual Care Expert, Mr. Obhik Ghosh, Head Connected Digital Health TCS Research, and Mr. Ayad Al Musa, Middle East Healthcare IT Leader, PwC. So, for our audience in the cloud streaming, we will take a break while you be with us with the Chambers video. And for our audience in the social media, we will come back in 7 to 8 minutes time. Thank you.
we are all products of our time. Never perhaps such words collectively meant their truest as the times that we live through now. Never before in living memory of its 187 years of existence has the Bengal Chamber witnessed a world so united in crisis, created not by wars, but by the global susceptibility to a virus of pandemic proportions. Yet, your chamber, as an institution and as a business collective, has worked and stood through unprecedented times brought forth by the viral pandemic and the devastating super cyclone, rallying all of us not only towards survival, but equipping us in being ready for life and business in the next normal. Just as Tagore said, if you cry because the sun has gone out of your life, your tears will prevent you from seeing the stars. The need is to adopt sustainability, adapt new measures, and practice the new economics of innovation-led progress to turn over a new leaf. Again, as the poet said, you can't cross the sea merely by standing and staring at the water. And so, we got down to work. The Chamber's yardstick of operations is usually measured by the number, relevance, and contextuality of its programs and activities. If a chest full of 110 events puts the stamp on quantity, the qualitative aspects of our program-led and results-oriented activities are certified by the way they have been received by the audience, professionals, and stakeholders from different geographies attending in impressive numbers in person before the pandemic and virtually since then. The year has hit us hard, and your chamber rose to the occasion.
চেম্বার অফ কমার্স থেকে আজকে 500 বেনিফিশিয়ারির জন্য ত্রিপল, ড্রাই ফ্রুটস, বিস্কিট, এছাড়া সোলার ল্যান্টেন, মেডিসিন, এই সমস্ত জিনিস তারা নিয়ে এসছেন, নিজে হাতে নিয়ে এসে এখানে দিয়েছেন। কিছু জিনিস এই স্পটে দেওয়া হয়েছে, রামগঙ্গায় যে মানুষ যারা এফেক্টেড হয়েছে বাঁধ ভাঙায় বন্যার ফলে সেই মানুষের হাতে তুলে দিয়েছেন। কিছু জিনিস আমার ব্লক অফিসে রাখা আছে, যেটা দূরবর্তী অঞ্চলে আমরা পাঠানোর ব্যবস্থা করবো আগামীকালই। তাদের এই শুভ উদ্যোগের জন্য রামগঙ্গার সমস্ত পথরপ্রতিমা অঞ্চলের সমস্ত আদিবাসীর পক্ষ থেকে, ব্লক প্রশাসনের পক্ষ থেকে সকলকে ধন্যবাদ।
If this was not enough, the sustained work undertaken during lockdown, supporting our government and the citizens was a part and parcel of our operational existence. As the days rolled into weeks, which spilled into months, your chamber embraced the new normal as the new walk of life. The Bengal Chamber, with its managing committee and the expert committees, under guidance of the past presidents and with overwhelming support from the membership and all stakeholders from near and far, embarked on a journey in which geographical barriers and distances were nullified. Digital and virtual became the realities of the day. This seamless transformation of bringing together people from all corners of the globe, addressing core issues of business, health, social and economic aspects is captured in a montage. What we have experienced is that our pre-pandemic and post-pandemic programs may have been held on different platforms, but the intensity of engagement from participants has only strengthened over these 100+ activities. The learnings were aplenty.
We will have to work in terms of taxation, in terms of policies for transfers to the poor. And I want to, though I'm saying that right now we cannot be obsessed with those big long-term changes, we have to worry about that very, very quickly, because the level of inequality we have in India is unacceptable and we have to work on that.
I know the NEP talks about it, and I'm totally in favor of having more of our base foundational education in Indian languages. And this needs to be, there needs to be a way of making sure that this is done even in elite schools. Otherwise, we'll end up with a two-track country. However, while the theory of this is good, the practice of it, however, needs to be thought about from a very basic perspective, which is that the textbooks and curriculums in Indian languages need to be radically upgraded and updated.
The SWOT analysis, which has been done by the chamber, it mentioned that credit is a major issue. Now, with this group,
Welcome to the 4th edition of Health Tech, presented to you by the Bengal Chamber and Medica Super Specialty Hospital. This session is Trends in Health Tech. It would be chaired by Mr. Arnab Basu, who is the chairperson of IT Committee, the Bengal Chamber of Commerce and Industry, and managing partner, East, and advisory leader of PwC. PwC is our knowledge partner. We have an overview of the thought paper being released in this forum in the earlier session by Mr. Sayantan Chatterjee, PwC Consulting Director. The thought paper is on transformation of patient journey in a virtual healthcare setup in the new normal. We are being joined by our speakers, Dr. Sujoy Kaur, Chief Medical Information Officer and Vice President at Apollo Hospitals. He will speak on ethics in digital health and clinical AI. Mr. Klaus F. Nielsen, Global Digital Health and Virtual Care Experts. He will speak on virtual care via telehealth. Mr. Obi Ghosh, Head Connected Digital Health, TCS Research on Wearable Technology, and Mr. Ayad Al Musa, Middle East Healthcare IT Leader, PwC. With this, I would request Mr. Basu to please take the session forward.
Thank you, Angana, and again, a warm welcome to all the viewers in this session of Health Tech. So, as Angana mentioned, the session is Trends in Health Tech, and we do have a fairly august gathering of speakers who are all specialists in their own fields who will talk about it. But I do want to, identify that we have chosen the speakers in a way that it gives you a 360 view of, how healthcare and, specifically patient care is getting transformed in the new normal. As I said, we would talk a bit about, Sayantan would talk a bit about the, thought paper that we've released, but I think it's a lot around, if you want to do anything in healthcare, really the foundation is around the data and around patient data, around health data, which in many cases is, of course, it's personalized and it's confidential. So we need to have the right framework of how health data can be amalgamated, how it can be prioritized, how it can be shared, how it can be even stored, because different countries have different legislations around even storing of somebody's personal health data. And so we would have a bit of discussion around that, and then we have been talking and hearing and probably even use telehealth for ourselves. So how does the virtual care get transformed? We'll hear about that. A lot of virtual care is possible, probably using a fair amount of wearable technology. So we will have Ovik talk about that with us. And when we talk of wearable, it's not just about what I'm wearing while I'm exercising, but what I can be bearing on a regular basis and what it can do to transform healthcare and remote care in a country like ours. And then, of course, you can't be doing everything yourself. We obviously understand the demand supply constraints in this country in terms of, registered practitioners of, health. So to that extent, how much technology can, take over, whether it's in terms of intelligent automation, running the operations, remote monitoring, all of these are very, very critical pieces of the puzzle if this needs to work in a country the size of India and the complexity which it brings in. I think I would say the advantage that we have as a country is, of course, the mobile penetration of the country is currently at such a level that, and the technology has become so easy to use in some cases that it is now possible to do this, not just with our, tier 2, tier 3 cities, but even in the hinterland. And again, what we are seeing is that in the new normal, even patients in the metro cities are choosing to go, remote, choosing to go virtual. So the trends which are emerging are quite interesting in a way, where people want to go probably faceless in an industry where traditionally people had not been, going faceless. And as we heard in the curtain raiser also, that these technologies have been there for some time, whether it's around, getting tested, around the diagnosis, telemedicine, all of these these are not new technologies, so to say, but it's probably also a change in the cultural mindset and the behavioral mindset where people are adopting it more. So I wouldn't talk too much in today's session. I would probably ask Sayantan if you can start off the session with your views of, what our thought paper has, sort of thrown up.
Thank you. I'll just be presenting the screen. So what we did as PwC is that we tried to work to backwards to say that what has literally this pandemic taught us, and what are some of the things that when I'm talking about virtual healthcare, as Arnav mentioned, some of the components have always been there. But what we tried to have a look is that what did this pandemic literally give that as a fillip? What are some of the things that it was not just a push, but what are some of the key aspects of what we called as a virtual care that got thrown up in a I would say forefront, where people started using it not just as an optional thing, but something which is very much part of how care is being delivered. And this is something which we believe is something which is going to be the cliched new normal, but something which is going to be the new normal in terms of how care would be delivered. Going not in the near future, but for some time too, and that's just for good. So I'll just take you through a few of the things that we look to cover in the paper. So what basically did the COVID-19 or the pandemic? What it did was, apart from all the disruption that it did on the economic front, on the socio-political thing, it also I would say interrupted the way we were living, for that matter. And because of that, and because of life that is related to health, so all the things that we had. So basically, be it increase some of the mental health because of social isolation, high degree of uncertainty, all the perils of working from home or anywhere, high attention to health. All this, what it did was that there was a whole, I would say, focus in terms of like how healthy or non-healthy we were. And all the stress and all the, I would say, some of the lifestyle diseases which came through it. So that is literally what it did. And all the things, I think, as you will relate, literally propounded the way that we were looking at health internally and the way we were looking to basically go about it. That was literally the first thing that came to the forefront. And what it did, because of all the things that we were experiencing as individuals, as a community, as a family, is to see that how that we looked at the entire thing of healthcare was being delivered and how we were expecting. So if we were to think about it, healthcare was always associated with a doctor and a doctor in a healthcare facility, be it a primary, secondary, or a tertiary setup, and getting a care or getting access to the care meant that we would be in the vicinity of that facility. When I'm saying vicinity, it in terms of the peripheral setups as well. So that is how it was. So it literally meant like seeing a doctor, going to a hospital, filling the forms. That's how it was. But given the constraint that COVID put on us, it basically made all of us realize that was it the form that we would like healthcare to be, or the care to be delivered to us. So in terms of it, like what it meant was that I was not too comfortable like moving out, or I'm not too comfortable in terms of going in a scenario which has I would say whole lot of chances of infection. And what I want as a patient is that can that care which was in the confines of the brick and mortar of those providers move to me. And I say move to me in a virtual mode, move to me which is in a sense which is the way that I need, when I need, and the form that I need. So all the things in terms of the personalized treatments, the things of being connected, what we were talking about, is something which all of a sudden became a reality. So during the lockdown, we were actually working with quite a few providers in the space, helping them as they were literally scrambling to be I would say be able to deliver care in this current fashion. So, and the first thing that is that how do I still be able to deliver that high care of care? How do I still get my care delivered, which is the doctors, to be able to treat my patient in the most effective way? How do I still instill that amount of trust within my patients to say that, hey, we are there for you, and especially in such a tough scenario that we are going in? And what was the means that we had? So in fact, I remember working with at least a couple of providers in the space where they had to say that, do we have the facility? Do we have the infrastructure to be able to do all of this? So all the things, it's like, it's one say to say that can we be doing it, but then how do we literally get about delivering that same amount of care? And it was not easy. It was something which it came about with I would say a lot of planning, but also in terms of other things which were literally pushed, and the pandemic was literally that push which helped us I would say do that. And what was some of the things which came up as a paradigm? It's like so rather than it just being on a device thing, something which is connected, content transparent. That exactly what was the fundamentals of the virtual care which was laid in front of us. And what most of the providers and the care delivery units said that how can I be basically enabling my care deliverers to deliver that care? So for a doctor who has always been delivering the care it's like seeing a patient in front, all of a sudden when the patients are not walking in, how do I still treat? And it's not just about the technology which enables, but there's a business process, there's a big amount of change management, which literally these institutions had to go through, and we were in as partners working with them in that journey. And that's something where literally the doctors had to be say that this is the new platform, this is the new tool, which is as intuitive as it can be, which helps you get that. And some of the things were there, but this is a forefront which this was basically the pandemic got them in the forefront to be used on I would say a very proactive scale and manner. And so when I say some of the things which came up in that, so one is the telemedicine concept of it. So one is that how can I be treating doctors being able to deliver care to the patients. The second care is the entire thing about the self-care thing. So when I look at a virtual care as a platform to say, so I need to be basically being able to not only get a visit or I would say consult with the doctor, but how do I basically care for myself, which is the entire concept of self-care. That is, it's not just about sickness that I need to be on this platform, but how do I have a mechanism to be able to be connected with my patients? And sorry, they may not be even patients, they might be your users of that platform in their wellness journey as well, which is the entire concept of being self-care. And literally the pandemic was a scenario where a lot of people were being, I would say, encouraged to be more I would say, self-knowledgeable and aware of this thing. Second is in terms of your digital records, because this was one time where everything had to be on that platform. So some of the things in terms of your records, reports, scans, how do I have that on a single click, on a single access, so as to say, which is the thing of getting the records in place. Teleconsult is something which I mentioned, which has always been there, but now it came in, and so as to say that it is a seamless platform for a doctor to be interacting. In fact, while we were writing this paper and some of the interactions we had, one of the points which came from a medical practitioner was that, can it be as simple as like the WhatsApp interface? And now WhatsApp is typically has laid that, I would say, benchmark of being simple, where I can literally click and I can see a patient, I can literally write notes, I can see the records while I'm writing the notes. Can it be that? And I don't have to worry what is the bandwidth that I have at my home. I don't have to worry about the security of the medical records. I don't have to be worrying that hopefully whom the patient that I'm meeting is the actual one. There is no duplicacy there. So all those things in a very simple, intuitive, and that is what literally when I look at a virtual care platform should be. For a medical practitioner, it should be something which is simple, intuitive, easy, but at the same time provides all the features and functionalities as if the patient is sitting right in front of you. Then the thing about smart monitoring, because a lot of cases where now you had to be monitoring the patients who were the chronic care cases, or the cases which were in the old age where they don't need to be literally coming to any health centers. How do I have the mechanism to be monitoring them? So can I get them onto this platform? So it is basically to say that I'm with you not only in your in your sickness, but also in your long-term care for that matter. And obviously the COVID-19 reporting, so as to say. So some of the things that basically looked at, some of the journeys that literally got transformed to say that I would now, instead of thinking about visiting any of the centers, and especially in this scenario where there was a lockdown, where in some cases people were prevented from going in, it was as seamless as taking your mobile or your laptop or your tab and clicking on it, getting registered using any of your social IDs or your registration that could be done, and in as simple as manner as getting, I would say, just like either a scan done or uploading your document and getting yourself registered, to consult being done, paying there, to the extent of even being able to order a test or a medicine and that getting delivered to your home, and then the tracking happening as the time goes on. So all that on one platform. And that's not something where people are basically wishing for, but that's a reality where quite a few of the providers have taken that space and are working towards that, and that's where the journey is. So it's not, I would say, disconnected, I would say, system, application, Windows. For them, it's just like one-stop shop. Can I be that one-stop, I would say, in case it be like an Amazon or a Flipkart, that one-stop shop where I can literally log in to that, and anything that I need from healthcare comes from that provider. And there can be multiple providers for that matter as well. So again, depending on the setup, depending upon the country or the geography that we have, and depending also how the provider network is within the organization, both in the public and the private space. And that's actually what all this push about virtual care is being. So it's as seamless as sitting on your drawing room. Obviously, there will be some of the invasive or some of the procedures for which you would still need to be. But for quite a few of them, you don't need to literally be stepping out. And in fact, quite a few cases were to say that doctor is literally coming home. In fact, we had this the scenario in the old days where the doctor used to come home. Now this is a similar case where the doctor is literally coming home on your screen, on a virtual screen as well. And the same goes for the doctor. Without, we will have to step out. Obviously, what it means that in terms of for all of, I would say, the key stakeholders, as to say, being the government, being the healthcare providers, the startups, the IT vendors. So there is a lot to be done in a collaborative manner, and it is being done. In fact, right from the government of India, what they did was in NDHM, which was a huge step, so as to say, where they laid out that How will this entire, I would say, digital platform be designed? What would be the means? So that's, I would say, a very, very welcome step from the government to be going ahead with, and where they literally said that was the rolling. And the providers literally responded in a very positive manner. So all of them were literally, this was something they were all waiting for. We say that how will this, especially the platform would be working. So and there's a huge responsibility on the providers to now step up to be doing that. So be it, when I say providers, and taking the hospitals, clinics, and the doctors in the same space. And what it did, and what is now done, not only did, is basically it's a journey which has been got accelerated. There's all the startups and the IT vendors. Literally, there's like, what it does is that provides them this entire, I would say, the gamut or the canvas to be coming up and working on this virtual care platform. Because it's to say that that can I have these solutions? Can I have these, I would say, modules and plugins on that platform to come in and literally start collaborating with one another? Because as a user, I'm looking at the experience. Literally, can healthcare be as simplified as doing an e-commerce transaction? That is literally the nirvana that we would be aiming for. And the startups and the IT vendors are literally working, I would say, very closely with the providers in taking that in that direction. And all thanks to the government of India for having given this in the time of the lockdown, this clear vision from an engagement point of view. But obviously there would be some challenges, so as to say, because everything has its, in terms of, like, as we say, things in terms of obviously the financial transactions, because it's not that, it's still, obviously we have a high degree of mobile, I would say, penetration, so as to say. But in terms of for any of them, the patients to be using these virtually, it still needs a setup that they need. But the intent is, as we're saying, that how do we overcome this barrier? So how do we take this entire thing about it as simple or a platform or as easy to use or as inexpensive an application or tool that can be, so that does not become an entry barrier for any of the patients, as we say. Similarly, from a provider point of view, the initial costs of setup and all, which used to be significantly high, has been now steadily decreasing. So, and more so because you have, I would say, a fair play of the startups, just to say, IT vendors in that way. So it's not just limited to a solution provider. It is not limited to a particular technology or solution, but as the way the platform goes, where everyone can come and contribute and work on that. That's exactly the model that's being worked out, especially from a virtual care thing. Technology, obviously, because there's no I would say, challenge which goes on with the technical. But the key thing is that technology, it's a challenge, but it's also the mechanism to overcome those challenges, I would say. So some of the things in terms of interoperability being worked out, network connectivity, all these would be there. The speed at which we are going, I'm sure that these challenges, I'm sure coming in the next 6 months, most of these challenges would have been converted into opportunities rather than just being challenges, as to say. Behavioral, that's the first key thing. I remember I was talking about this to one of my uncles who's quite elderly and he has a chronic case, and I was saying that, are you sure that if I see a doctor on my iPad, he will be able to understand how am I feeling? So that's behavior for me. It's like, so can I trust that care being delivered through that platform? Can I trust that without having to move an inch from where you are, I would say the best care would be delivered. You would be able to order your medicine. The tests will all happen. So and not only that, it will be through a health companion, so as to say. So can that be there? So it's like literal to say that, can I have a health companion on that app? That's exactly what a behavioral change would be. Systemic, obviously, like all things, that there's no in terms of some of the mandates, some of the reimbursements, because there will be a lot of play between how the payers, the providers integrate. So all that will be there. But I would say, although these are the challenges, but these are all the opportunities as we go ahead to make this virtual care a reality. And that's exactly the message that we have. And typically, as PwC, we are working, as I mentioned, across the value chain, right from and with quite a few providers. I'm proud to be saying that, where we have helped traverse this journey with quite a few of the providers and making this a reality, not just about telling them what can be done, but not just the art of possibility, but making that possibility a reality for them. And that's I would say the message. So when I say virtual care in the cliche new normal, that's something which we are very proud that as a country, as a healthcare community, we are literally embarked on. So that's thank you, folks and gentlemen. That's all from my side.
Thank you, Shanta. Okay. Can we have Shujoy? Shujoy, would you speak next? Shujoy is speaking on ethics in digital health and clinical AI.
Thank you. First of all, a lot of thanks to Angana and team, to the BCCI team to actually invite me for this particular health tech conference, digital conference. Am I audible? Hello?
Yes, you are.
All right, thank you. So the topic that I was provided, and I thought it was quite relevant for the kind of the discussions that we're going to have today, was on ethics in digital health and clinical AI. And I'm going to talk about today on practical experience of, developing, validating about a couple of dozens of clinical AI solutions, working with the digital health platform 24/7, Apollo 24/7, that has been very recently launched. It's almost a year now. And what kind of frameworks that we have been able to develop within our systems to actually deploy them into the workflow of clinicians and to see how it augments their day-to-day practice. And I was hearing, Shanta, on an incredible work there on the paper that you had done, wherein there is a journey that the patient or the doctors or the clinicians are going to do, and they do completely on digital. But then there are certain questions, as I said, some challenges that you would face particularly on an ethical perspective, because we really don't know what is happening behind the black box. And that is where we want to go, see, understand, and it has to be explainable in many ways to actually work fine for all of us. So one of the things that we have been able to do at our institution across the network is to implement a policy, what we call as EASE. And EASE stands for ethical considerations, the principles that governs the ethical aspects of developing, validating, deploying AI and digital health. And then the important question of adoption. It always boils down to how much you are consuming the kind of technology that you're trying to build, whether, what are the change management that you're doing within your organizations to actually help them see the light of the day or the purpose of building them. And then comes the very important question of suitability. This acronym may not be staged in a way that it actually goes one by one or goes sequentially, but I think it covers what we necessarily want to look in a framework. And the suitability is the next one, which actually says what works and what doesn't work. And I was in a discussion yesterday by a very prestigious philanthropic organization who wanted to do some work on, child health and maternal health. And we boiled down to the question of suitability if the solutions that are going to come out are actually going to work for that group of people. And then the all-important things around the AI, and this is a debate that is going on world over, is about the explainability, how the clinical AI models or components of digital health are easier for understanding. And Shantan gave an example by saying about an elderly gentleman who wants to know the value, the trust that the system encodes within itself to be workable for both the sides. And in that context, let's take up some of the things around the ethics part. And the first thing was about safety and non-maleficence. And, this is something which comes from the very core of the ethics in healthcare or in clinical medicine that we have to look at. But if you see on the right side, and this is something which came up in BMJ a couple of years back, it talks about how things are now moving from rule-based systems, clinical decision support systems, to supervised machine learning, to what we are now working on as a part of our certain high-grade AI tools like reinforcement learning, and how with those technology, bringing in simulations, reinforcement learning, and stuff like that are improving overall accuracy and integrity of models, which would help go and see that how they are going to be reflective of what exactly clinicians want in their individual workflow. But having said that, one of the important aspects that comes with safety and non-maleficence is about the whole idea that the model or the data with which you work with, is it inclusive? Is it something that can be used world over? And I bring a couple of things from the MIT Tech Journal and the 3 reports that came out on that. And the first one was about AI-driven dermatology could leave dark-skinned people behind. They would not diagnose people who are having certain lesions, including melanoma, in dark-skinned patients because of the fact that the model was never used those kind of data to actually for the training purpose. And if you don't see it in the training, you probably will not see it in the output or the outcome. And what they found out was that a lot of patients were being missed out in that. And the second was equally interesting. It was one of very good hospitals in Boston who developed an algorithm to actually follow up care in hospitals, particularly looking at readmissions. And that was particularly biased against people with color. And what it was doing was that they were not getting enough opportunities for readmission when that was warranted. And that was the algorithm was actually failing to define on that. And the third thing is this, that we have this ever-increasing population, elderly population who are now moving to digital technology or who have already moved into digital technology. And they're looking into conversational AI in health, concerns of triage, when to report to the clinics or to the hospital emergency and stuff like that. And finally, I'm going to touch about a topic which is basically about decision-making and clinical handovers, which are also very, very important. The third thing is about the accountability process, where how do you design? What is your intended use? How do you look at the retrospective data, or what are your structural vulnerabilities on the entire workflow of developing and validating a clinical AI model, or even for the digital health model? And this is one of the papers that came up again in MIT SMR, which looked at particularly on scoping, mapping, collection of the artifacts, testing and reflection, and looking at the whole process in a way that would make it more auditable and accountable going forward. The next one is on the efficacy, and we have looked at efficacy in a very different way in traditional studies, but in AI, we would have to look at what works for you in the retrospective data may not work for you in the prospective way. And there are good tools to use, actually. There are tools like there are tools and metrics that are available in terms of precision recall or predictive values or likelihood ratios, which are coming more and more prominent as we see more papers happening around clinical AI and all of that. But I wanted to talk about this accuracy, and we know about Google Health, and in fact, I have been also in one or the other way part of this work. And the algorithm that they developed for detecting diabetes retinopathy was excellent when it was getting trained and when it was going through the initial validation with the retrospective cohort. But when they implemented it on the ground, they found out the efficacies were down by almost half. And the accuracies were falling down in that way. And the reason being, it was the time that will be taken for rejection or retake of an image, particularly in senior citizens or other population. And then, of course, the whole purpose about connectivity, internet connectivity, and stuff like that. The other thing is that what actually didn't work out for them was that they didn't focus much on the workflows. They were doing an excellent job towards the building the model and validating it, but they were not actually focusing on the workflows. And that's where when I go back to my teaching classes at IIM Calcutta, I always tell people that the digital is not just enough. You would need to actually have, sorry for this, you would actually have to have stuffs like design thinking brought over on the top of clinical AI to actually make it more relevant. The Achilles heel of AI is about the integrity, is about what you're putting into your data that comes out as an output. We all know about the GIGO effect, the garbage in, garbage out, and all stuff like that. I want to focus on fairness and inclusivity, and that is one of the main problems that we face today with digital health or ethics and stuff like that. And that is one of the things, and I heard Dr. Rupali Basu speak about using Aadhaar card and COVID vaccination drive. And I want to bring into a study that was published from India onto WHO bulletin about a couple of years back. And this study actually talked about when the Aadhaar card was linked with people with HIV, people living with HIV and tuberculosis, associated tuberculosis, the dropout rates for people, because their Aadhaar cards were actually exposed, was staggering. People did not went up and picked up their the heart medication and others highly active antiretroviral therapy medications, because they were exposed to, the data sets were exposed and people could actually identify people with living with HIV with their, with their Aadhaar card. And that got published in WHO, and you can understand the connotations of this, which is not just about a clinical, but also socio-economical, and also about, the whole ethical principles associated with it. The other thing that is very exciting about looking at ethics is the whole context of bias. And we've studied the bias in a very, very distinct way. And we've seen the bias comes from model development, in which you pick and choose or cherry pick your population and then show some results and see how do you go about that. But bias also comes in when you are actually deploying that thing, in which are the group of people that you are actually going to use your digital health, or you are not going to make it to a section of population and not to the other section of population. So that those kind of things are needed to be addressed where you are developing solutions for clinical AI, or even for that matter digital, in that way. And we can go on and on discussing around bias and all of that, but I thought it is important to actually look at the bias also from the deployment perspective. So to summarize in terms of the adoption perspective, what are the other things that are required? And I think the previous speakers talked about interoperability and universalization. They talked about calibration and benchmarking, understanding the clinical relevant outcomes, and of course, looking at patient safety as such. When you have all of these components, your adoptions are going to be used. I've come back to the other very important aspect of this is actually the suitability consideration, where the first question that you need to ask is what clinical or public health problem that you are going to solve. Next, address the bias. Third, look at what exactly the knowledge interpretation or the causal structure or, the kind of information that you are going to generate. And lastly, you would have to think that anything that you work with has to be in a way that clinicians and AI come together. You have to augment their workflow. And in that way, you have to understand when the algorithm hands it over to the clinician and the clinician hands it over to the algorithm. That is something that is still under research, but that is something which would actually help in rolling out more and more of digital programs and clinical AI going forward. Explainability is the last portion of this. If you look at the steps around the explainability, you have to find out you verify before deciding. And this is particularly important for the clinicians. They would need to understand, build the trust in the system, and convey that trust to the patients to actually make it that way. And the third thing is, it would become more and more relevant when we actually move from prediction to, and Dr. Ravi Chakraborty was talking about predictive medicine. I think what is important in going future is to actually bring causal inference to the prediction, where we are able to understand that this decision of mine, by providing the patient the chemotherapy and radiotherapy, is going to have an effect over the 5-year survivability on that. And what if I didn't choose those two and I choose the surgery over it? What are those kind of models going to give us? What are those kind of understanding going to give us? Those kind of things will make the system much more robust. And of course, the new clinical insights are the other part of the story, which also always goes to come in, particularly in drug development and other areas as well. So this is the work that we very recently did with World Economic Forum, got published in December 2020, where we actually deliberated a team of about 8-10 people worldwide. We worked on to develop a framework which was probably going to become the standards of preparing clinical AI or chatbots across the world. And this is being done through one of my friends, Mr. Venkat from Mitsubishi, who actually worked with World Economic Forum to develop this. So my last slide, so to put it in this way, if we could just ask the right questions at the time to actually see more inclusiveness and fairness in the whole process of building digital health or clinical AI. First, what is the process of decision-making and oversight? What are the benefits to the society, to the people, to the clinicians at large? And have we worked around a dynamic and informed consent, evaluating or communicating about the risk? And what are the stakeholders able to participate into that? How interactive that is. This is something which comes from IEEE. I find this as one of the ways by which we put in how we bring in more and more ethical standards into clinical AI and digital health. Thank you for the opportunity.
Thank you, Shreya. So, Klaus, can you have you go next?
Yes, please. I will start share here. So, can you see my screen? Yes. Okay. So, thank you so much. So, I am Klaus Nielsen, and thank you for the opportunity to be able to join you virtually, unfortunately, in India, in Bengal. So I'm the co-founder of the Data for Good Foundation. I will explain about it, but it's a Danish data intermediary I've been working with for 5 years. I'm in the board and have been co-founding it. It's about trying to enable to represent the citizen in the data economy. I'm currently sitting in Bangkok, so it's getting dark here. I'm looking out at the skyline. So I've been here for the last year, I haven't moved much, and I'm the former vice chair of Person Connected Health Alliance, which is one of the organizations trying to make interoperability within the Person Connected Health space. If anyone wants to, let's see if I can move to the next one here. Yeah, now I can. Yeah, so if you want to tweet or you want to do something, this is my handle. So just to make it very brief, I'm Danish. If you Google it, you will find this. So technically in the US or UK, I will be sold as a Danish. I'm basically born here, but I'm now on the other side of the planet. Let me make it brief. Just tell you a little bit about Denmark. So Denmark has a tax-paid healthcare system, which costs the half of what it costs in the US. This is even old numbers, it's probably worse now. It is very high quality. It is for all, even poor people, and we have a very good satisfaction rate. I don't think you can say the same for US, even though they claim we are socialist, but that's okay. I'm happy. So just to let you know, in Denmark, this is my background. When I work into this space and understand it, I can buy and sell a house 100% digital. And I've even tried this. I got a digital divorce in 5 minutes, so I can highly recommend it for people that want to get rid of stamps and paper. And I know I talked to you in India, you can't even believe this. This is my world, okay? What you're doing in India is trying to develop unique personal data. You're doing a hell of a lot of work on trying to get data in on people and have a unique person identifier. We have had that since the 70s, meaning that we have unique personal health records. This is showing my personal health records going many, many years back. Just to let you know, we are talking about virtual care. This is something where in my country we have had it implemented nationally since 2013. We have even very, very good cost savings on a public healthcare system, how much you can save. Even though we have it, it's still a challenge on the adoption side. I implemented my first aging at home remote patient monitoring projects back in 2007, and some of them are still alive using the same equipment. One of the challenges has been, even though we are one of the most digitalized countries in the world, is to get doctors on board. And this is one of the learning points that I still wonder about, is we spend maybe 8 to 10 years to get our private GP system, which is technically a private system that is reimbursed by the government. But when they couldn't see any people, they will not get paid for any consultations that get paid by that. So that's we didn't manage for 5 to 10 years to actually get them to adopt video consultation. But with the pandemic, also as we heard, this suddenly changes everything. So it's not a technology issue. This technology has been available for over 10 years in the Danish public health system. It took 4 weeks to get almost 100% rollout. This is only a political decision. So if you want to be virtual and there is benefits for it and it starts to hurt financially, people can get things done. Let's change topic. So this is my old home in Denmark, which I don't have anymore. I'm now based in Bangkok. I have no intentions of going to a COVID place. I'm happily safe here. But this is my old wooden summer house. I have, of course, equipped with sensors. I had all these gadgets. I still have them. I have exchanged some of them. The weight scale is here in my bathroom. I still have the blood pressure monitor. I've had them for 11 years. As everybody knows, we do a lot of sensors. And now you can see my video. So one of the few gadgets I do absolutely not want to have is to measure my hair health and hair quality. So I don't buy this one. Just to let you know, I am a quantified self guy. But let me go back to something that is much more interesting, because what I see here is a real pandemic in terms of using virtual care for something good, is to battle this pandemic. And this is, I have not taken India into this equation. Just took some old numbers from Southeast Asia, where I'm placed right now. And this is even worse. This is worse numbers we have now. This is leading to a lot of the diseases we have. And at the same time, in this part of the world, we have a lack of access to clinicians. So this is where the virtual health, the remote patient monitoring tools, whatever you call it, anything with devices, can start to do a big difference. But before we go into that, let me explain you why I a little bit know about this. And let me explain, just sorry, I have to put a disclaimer. This is me. It is in 2007. And the formula you see down here is the formula for body fat. You can see it here, right? Here you see, that is the formula for body fat, if you don't know how it looks like. And I had way too much of it. And I got one number in my GP system that nobody reacted to me. This number means you're pre-diabetic. I didn't know what that meant. A simple machine. This is not a lot of data. We just talk 2 digits that could have warned the doctor on the screen, this guy is he has on a blood glucose lab result a number 48. Nothing happened. Of course, I was later diagnosed at diabetes 2, so I don't want to be a diabetes 2 patient. So I started my work of trying to exercise, and you can see how much it worked. Not only exercise, everything that is needed to reverse my diabetes. And I came back to the green area. If you look into the data I collected, how much exercise means when having a good control of your glucose and not having a glucose control. Here you have my data. These are my data. I don't share it with anyone. I share it with Roche, and they probably use it for some AI. They don't know what I eat, but this is my food. I love to make food. So I changed my body completely to look very ugly from 2007 to 2017. Unfortunately, my journey is I still kept being diabetic. I got probably because of the way I was eating, I don't know. But I got a cancer diagnosis in 2017 that set me back on my. So the whole problem with my diabetes has probably been related to my cancer. I survived. It was found early. This is also a good thing about, if you know that I have cancer, that I have diabetes, what I'm eating, some of my symptoms can actually detect some cancer types early if you have data from me as a person. But we don't have access to that as of today. I was luckily found in a hospital here in Thailand. I'm happily cured. But what I'm actually looking at is just take a use case for some of the things we are trying to help people with. So the use case of virtual care and remote patient monitoring is diabetes. We have an explosion of diabetes 2 and now also diabetes 1. This is one of the issues. Only 6% is in good control. And diabetes is a complicated thing. It's like you have to navigate when you cannot produce your own insulin for either for different reasons, either because you're attacked by the body at diabetes 1, or you I don't know how many of you guys know this disease, and then diabetes 2, which is lifestyle, where your diabetes get less efficient. So there is like millions of people living with this caused by the obesity pandemic. This is killing far more people than the COVID right now. And we are not having a lot of tools to combat this. So it is like having if you think of it as a flight captain that has to navigate his glucose level, where it's where you have insulin. Insulin is controlled by what type of insulin you have, basal insulin and then the rapid acting insulin. Then you have to know how much carbs there is in food. Then you need to know if you have been active, not active. Are you planning to be active? Do you have any diseases? This is a very, very difficult task to be in control of your diabetes. My son has diabetes 1. He knows that. He dreams of having tools like an airline captain, not to crash if he's too low and injects too much insulin, or get up in the sky because he's sky high because he eats something that was carbs and he didn't know. So let's take a simple case of how complex it is when we talk about making the data input just for handling diabetes, which is a pretty normal NCD disease. And this is actually tools I'm using today. I'm using these tools here. The glucose pen cannot right now. This one up here cannot yet transmit data, but I know they're working on it. So technically, the only missing parameter I have is the food, where I'm trying to use some AI tools. Trying to get this into this kind of system we have in my country. I'm showing Endomondo now killed and we things, but we have a lot of data in the cloud and difficulty sharing it. I've been working with this topic, so one of the challenges of bringing virtual care to the masses is to get the interoperability. It was mentioned before, and it's still the same problem. And then if you can get that, you can get my data. So my data, here's my weight data since 2011. And for me, battling with, now I'm a type 1 diabetic, because you can see on this, I got this number and I couldn't understand it. If I go back, I go back to this one. So what happened here is I suddenly lost a lot of weight. I got my cancer here in 2017. You can see here that I was going down in weight. I was in pretty good shape. I've been exercising, as you can see on my stats, and I have been moving my body fat around. And now I suddenly became a type 1 diabetic. So this is data. And now I have this one. But you know, I have more questions than answers. And if you look at the healthcare system, it is not patient-centric. No matter what, sorry doctors, but what you say to me, now I take the role as a patient. No, it is not patient-centric. We have the oncology, which is and has to be highly specialized. And I don't expect them to understand much about my diabetes. And that is just how it is. That's in the endocrinology field. And this is patient-centric system that when you talk to a hospital, they say, yeah, we have the patient in the center. No, you do not. Actually, I'm left alone. That is how it works. I have accepted this fact. And I know it's not easy because I've tried to innovate public health system for long. And it is still, when we look into the model of healthcare, it is still a one-size-fits-all where you all find, I think in the Rania Hospital, I saw that at Dr. Shetty's office, he said, healthcare is only about price and protocol. And I guess he's right. So what we are trying to do with the virtual care, what has the potential, is to try to make this shift from sick care to healthcare. Because what we are looking at now is we are only doing where there is an accident. Why didn't I get notified when I was 48 in diabetes that I could actually reverse my diabetes? Maybe they've even found my cancer and other stuff because you can see that. But there is no feedback loop from these data coming into my digital records yet. There has been no AI put on it to make alerts and warning systems or whatever. But what we can do is we can try to work on trying to focus more on this part of the system because this is where we end up, and we generate a lot of cost. So if we can try to stop that, that would be a main goal. So what happened to me is I got diabetes 1. So I'm trying to get help. I'm measuring my data. This is just one app that is one of the most popular one called OneDrop, where it takes data from a lot of sources. I'm not able to share, I can share this to my coach. And this is the interesting part. I have now a coach that looks after me, motivates me, because one of the problems when you have a chronic disease is, and you can reverse it, is how can you get out of it? This is into the self-care we are talking about before. So now I measure myself. I can share these data. I cannot share it to my doctor in Denmark. I have to send it very, very old school on paper in PDF to a very, very secure email address. And she doesn't get the data in between my visits, okay? So now I have subscribed to a private service. So this is one of the issues of the data sharing. We know that it's happening and people are taking my data and it's being used. We know that Google is using it. We don't even need to apply anymore. They know everything about what we are doing, what we are talking about right now. I think everyone in this room knows, if you haven't seen the documentary on Netflix, go and watch it about the Cambridge Analytica scandal. But what we see now is quite interesting, because I have a lot of data. I want to share it. I need it. I would love to share it, but in this world, there are some people I don't trust. Right now, we have, let's say, a possible digital divorce coming up between these two guys. It's quite evident. It's also quite evident that we have lost control of our digital lives. I have so many apps, they are spying on me, they are taking my data. You can see what happened with WhatsApp when Facebook set new privacy rules and people flocked to Signal and Telegram. Honestly, as a private citizen, I think we have lost control of the data we are creating in all our apps. This is a big issue, and I'm happy you mentioned also the trust issue previously, also the previous speakers, because creating trust is something you have to earn, okay? So when I create trust in a relationship, I have to earn the trust in my relationship that I'm a good guy. If I have to have trust in a currency, it's something I earn. We tend to forget that. Now, if you have trust in the dollar, it's backed by the US government. So yeah, I'm just telling that creating trust is a problem. Let me go into another topic, which is interesting, because all of these data is about how can we trust data, and then right now our data is being abused by a lot of data, both governments, but also I think there's about 150 data mining companies. And I know this is a big industry, and I don't think we can stop it. It's also okay. But the European Commission have tried to do something about it. And you probably heard about GDPR. Here in Thailand, we now have PDPA. I think it's a good thing. If we can try to control our data, that we can make it easy, securely, and simple. So some of the things I think is interesting on terms of talking about how we can get AI to be enabled is how can we easily share our data, do our consents. So I'm working privately on a blockchain that is a private preserving blockchain that technically works on the new decentralized web. It could be like a health kit. You see here the kind of just think about the health kit model from the Apple iPhone, where you then can see who you get access to. And we try to test that on several remote patient monitoring and Vital Beats app from Denmark. It's a Danish project where we then can control this. And then we combine this with something quite interesting where you can do this secure multi-party computation where we have computing nodes, so we can actually anonymize my data. And why we need that is take the example of tracking of COVID, where Singapore police went in and used the data for criminal purposes. Now it was illegal, and now they have legalized it. But do you think people want to now use the app anymore? Trust is something you gain, and we try to make a infrastructure now where we can actually do this. So just quickly to do commercial of what I've been spending 5 years without getting paid, and investing my own money with a lot of people in Denmark is to do a data foundation structure where you can have citizen control, transparency, overview, and cooperation. And we are testing it out with a lot of pharmaceuticals. And this is how I think that my data, combining the story, can come back from what we looked at before, my private data, together with public available data, my Danish personal identified data, and maybe my genome data, which I then give access to APIs, so I don't technically move the data, to a consent hub that is then run by a privacy-preserving blockchain. And then we apply this cryptography multi-party computation, where we then can give access to analysts to give back insights. This is a data ethical way of taking my weight data, my private data, my glucose measurements into the system, get it back into me as insights, and that is how we should do it. And I could even get paid for this, and that's why we call it a health data exchange. And now we have a fair data economy, a fair solution where my virtual care apps, all my data I collect combined with this can work. This is a little side topic, I know that. This is our portfolio, this is the partners that we are working with. But I want to finish this, and I know I went a little bit off topic of the virtual care, but I think what we are aiming for is that I can get a self-care model where my data can be used to advise me on making changes in my current lifestyle, how I sleep, because I know it affects my data, it affects my life. If I don't sleep properly, if I'm not exercising, if I'm not healthy, and I think the healthcare system needs to accept that they can't solve everything, so we need people in between. A new growing business is the wellness coaching business. This is the one I'm working with here in Thailand in Be Healthy Asia, where we try to help Phuket that has empty hotels, fitness coaches, trainers, chefs that can learn about food, do the education part about patient, and try to help people get motivated to not end into the expensive healthcare system. That is my 10 cents. Thank you for listening to me. And if you want to get hold of me, here's my credentials. And I will now stop sharing and love to engage in a discussion. Where is the stop share? I have to go here. Yep. Zoom. Okay. Stop share.
Thank you, Klaus. That was really interesting. So can we have a pick after this?
Sure. There's a break now.
Okay. No, I don't think we are taking a break.
Oh.
Okay. Or did Angana suggest a break? Angana, are you there?
So we are going ahead with the session.
Yeah. Okay. Thank you. So, Avika, over to you.
Sure. Good afternoon, evening, and morning, everybody, based on where you are. And I'm going to talk about a little more technical topic, that is how to use and how well wearables have been used in healthcare. So do let me know when you can see my screen. I'll try to share it. Hope you can see my screen now.
Yes, your screen can be seen. Yeah.
Sure. So here we are going to talk about how wearables can basically help in remote care or remote healthcare. So here, basically my talk, I will cover more on the current state-of-the-art wearables, not like very specialized wearables that may be designed specifically for certain use, but what we usually have with us right now, and which is the smartwatch, right? So what all can we do with a smartwatch that exists with us today? So one thing definitely I think the Fitbits and the Apple Watches of the world have been doing for long has been activity monitoring, right? Now, well, they do activity monitoring. They basically concentrate more on step-based activities. Recently, Apple has come up with some fall detection algorithm on their wearable. However, the band or the watch can be used for detecting more complex activities as well, including activities like eating or smoking, which also give good insight into what the patient has been doing or what the subject has been doing throughout the day. The second parameter of interest, which has become very much of importance now, is the proximity. So when I say proximity, is the same as what we detect for this COVID, the social distancing. So we can detect and monitor interaction levels also using the smartwatch, because most of them have a Bluetooth built in, using which we can do some proximity sensing. Some physiological sensing, of course, most of them have a pulse sensor, and they also have some of them have ECG as well, but we will concentrate here on the pulse sensing. And finally, you'll see how the GSR, or the galvanic skin resistance, present in few of the watches can be used for some cognitive sensing as well. So moving into activity monitoring. So while as I said, like there are the step-based activities are being monitored by most of the wearables, that only provides a very scanty view of the actual activity that the person does throughout the day. So there are many activities that the physician may be interested in, especially for a patient who needs some assistance. So meaning the activities of daily living, like eating, exercising, brushing teeth, whether they are doing it properly or not. Now the problem with this approach and using the existing wearable is, while it is good enough, the wearable batteries or the wearable power is good enough for detecting activities during the 2 hours of exercise that we do. If we try to monitor all these different activities throughout the day, then it's a serious battery issue for the current wearables. So we tried to solve this problem, and we designed a hierarchical classification model, whereby we could actually use the AI to both optimize the battery as well as detect which sensors need to be turned on at which point. For example, the accelerometer sensor on the wearable or the watch is the least energy hungry sensor that is there. So we can opportunistically turn on the accelerometer at a lower sampling rate to detect if there is an upper body gesture happening. And once we can detect that the arm is moving in the way of some activity is happening, we can turn on the gyro, which is a more energy hungry sensor, to detect whether the person is actually eating or smoking or brushing his teeth, right? So these kind of trade-offs can be done, and throughout that we could show that we can actually map the day in a life of a subject. And this was done on an elderly care facility. So basically we are monitoring geriatric patients for their daily activities because they are basically living alone in ambient assisted living scenarios, and this was the work we had done. So I'll move to the next one. So this is basically the same thing that Arogya Setu also does. So this is proximity monitoring. However, what we realized is that apart from monitoring proximity to give risk score, it may be also interesting and maybe also important in enterprise scenario when we open after COVID to also give some real-time alerts on to people if they are coming too close, right? So can we use the watch or the phone to give real-time alerts? So that is like, it is more intervention for prevention rather than just detecting that okay, you have been coming in close contact with somebody. So even if the we don't know whether the other person is infected or not, we can enforce in some way that yes, you should be that 6 feet or 2 meters away from each other, right, at all times. While this does not hold good for home scenario, but we can use some location trigger to turn it on only when the person is in the office or enterprise scenario or the factory scenario, where by we can ensure that they don't come in close proximity with each other, and if they accidentally do, they are given an early warning, right? And just like the all the apps in this, we also keep the data anonymized and expose the identity only to a trusted server, whereby only the fact that you have been in close proximity to somebody who got infected is only the part shared. So the identity of the users are never shared across devices. So the third one is again using what we call the pulse sensor that is there in all wearables. So while we know that this has been used widely to detect heart rates, what we tried to detect was the cardiac fatigue. So what do you mean by cardiac fatigue is that when you do an activity, which is also can be detected easily using a smartwatch. So if we can detect that you have done the activity with a certain MET value for a certain duration, so we can see whether you are having the rise in heart rate that you are having, or the rise in breathing rate, the dyspnea you are having, is correlating or corroborating with the kind of activity you have done. So let's say a 40-year-old person with certain BMI has done certain activity, then is it normal or abnormal for the person to have certain level of heart rate increase and certain duration before the heart rate again comes back to the basal heart rate? So using these, we could actually determine if the person was having some kind of cardiac problem or cardiopulmonary problem, whereby we can detect that there is a abnormal raise in heart rate or dyspnea or other problem that the person is facing after a normal daily activity, right, like climbing a flight of stairs. So this was another work we had done. And the third and final work that I'm going to discuss is about this mental workload analysis. So here again, what we had tried to do was that given a task, can we use the wearable sensors to understand what is the level of mental workload or stress felt by the person during that task. So since it is not very ethical to actually provide some stressful work to a person, so what we did was we could determine, we designed a game which had two levels, like boredom and flow. So the game was very slow, then the person would get bored, and then there is a flow state where a healthy stress is being applied. So we saw that we could actually use this GSR signal to separate out the boredom and the flow states, and we could devise a score which could tell what is the level of mental workload that the person is facing. So this can be used for many cases, like when an elderly person is doing a task, or when a student is taking a lesson, or any daily task. We can monitor whether the person is facing some undue stress, and we can possibly intervene and help that person. So these are few applications which can be done using a state of the off-the-shelf wearable sensor. wearable device and the sensors that are there. So yeah, that is it from my side. I'm happy to take questions. I'll stop sharing now.
Thank you, Vic. That was quite enlightening. So that brings us to Al-Musa. Hi, Al-Musa, would you go next?
Thank you so much. And first of all, I just would like to thank the Bengal Chamber of Commerce for the invitation. Very interesting topics and very interesting talks. I'm just going to conclude perhaps the session with maybe some overview. Some of this stuff has already been covered already by my colleagues and the speakers. And it's very exciting to see that there's a great level of commonality when it comes to digital and healthcare. And my topic that I'm going to be covering in this session is slightly delving into kind of some of the AI use cases and automation in general. We've come obviously to learn that automation is highly utilized in different industries, but when it comes to healthcare, somehow it has, in a way, has been kind of lagging behind a little in terms of embracing and adopting these technologies for the better of patients, clinicians, and outcomes in healthcare system in general. So if we look at AI and automation, it has actually become pervasive in lots of areas within healthcare, whether be it staying healthy, as we saw from Klaus and his ability to deal with the various myriads of issues that he's had over his lifetime and dealing with those, but also staying healthy at the same time. In the areas of early detection, and as we heard from some of the speakers, wouldn't it be great if we could use the data and the technology to push the onset of diabetes, cardiovascular diseases by many, many years and actually have them detected early so that the healthcare system can actually deal better with dealing and with those issues up front and avoiding any episodes or complications or ending in hospital, which effectively ends up in costing the healthcare system quite a lot of money. For every hospitalization, the average is around $3,000 to $4,000, whereas for a few dollars, you could actually keep people healthy and avoid having complications. In the area of diagnosis as well, we know that from approved applications, FDA applications, that going through 300 images, a human can take about 30 minutes, whereas a machine can actually take 30 seconds. So again, enabling much more efficiency and much more accuracy, as a matter of fact, with a great level of accuracy to diagnose cases as and when they happen. Supporting in decision-making, of course, there is any human brain is unable to deal with the many data points that are thrown at a clinician from data for the patient, social determinant data, journal data, and so on and so forth. Is inconceivable for a human brain to be able to process all of that efficiently and within a short period of time to be able to help the patients or help the people at large. In treatment, in end of life, supporting with robots, for example, to take some of the mundane issues or activities that a patient has to go through and giving them a level of dignity in terms of being able to look after themselves, but using some other, and not being a burden for family or relatives or friends. Although obviously the human touch is very important when it comes to that, but helping with some of those activities in terms of using a robot or so on could help in that aspect. Research, we've seen, as a lot of the speakers have spoken, in this area, the pandemic has accelerated, in fact, the use of AI automation data mining, insights to help basically track the disease, the outbreaks, and so on and so forth, but also, expedite the process of quick vaccine, for example. In the area of training, using augmented reality or virtual reality as well, performing operations remotely and in a training kind of environment as well has been possible using automation and AI. So as we see, it is pervasive and it's prevalent in many, many areas. The problem with it all, as some of the speakers have mentioned, is the acceleration in terms of adoption of these technologies and making them more mainstream, as opposed to a pilot or a nice to have, or something that we think about as being on the side and not being utilized in the business as usual of delivering care. Now, that has not been possible, of course, without data. And we've heard from many people today that data is at the essence of digital health in general, and more specifically for AI and automation. So we've seen, obviously, the digitization of our point of care systems throughout the early 2000s. So we've had this tsunami of data being collected. More recently, from 2016 to 2020, we've seen the data fusion, so bringing different aspects of that data, not just from a clinical perspective, but also from social determinants and demographics data and all the various sensors that my colleague has talked about, and fuse that data and actually try to make sense of and correlate some of those aspects in terms of, if I live in a certain area or a postcode, I am more susceptible to having certain illnesses or certain aspects of my healthcare, as opposed to others who live in different areas. So again, fusing that data and understanding really what it, how it could be utilized for the well-being and the better of our patient. And then we're seeing more of the commercializations of those. So, we've collected the data, we fused it, and now we're starting to see commercial models, which is, as they say, money keeps the world turning. How do we actually commercialize those solutions and make them viable for hospitals, clinicians, and technology companies, but as well more affordable for consumers as well? And then moving forward and looking into the future, and this has probably been accelerated even further with the pandemic, is how do we actually make that mainstream and drive the adoption of that across the different segments of the population? And more importantly, as many of you have spoken, bringing the clinicians on board to feel that they're part of this ecosystem and not replaceable by some of these technologies. I think there is a genuine fear that some of these advancements in technologies are going to come and replace the doctor. And I think the view that we have is that these are complementary and supporting the clinicians, but not outright replacement. So we've seen different waves becoming more more mainstream in terms of driving in the last decade the medical products in terms of equipments, consumables, and so on and so forth. Now we're seeing, of course, the surge in terms of big data, wearables, and health analytics, helping us to kind of understand and make sense of all that data, moving into kind of the current and future in terms of focus more on prevention, as we saw from the previous speakers, and having all of that wealth of data and richness of data to help us kind of focus on, what does it take to help certain segments of the population avoid becoming diabetic or obese or suffer from cardiac episodes or complications, and how do we bring all that together to help in the prevention side of things? And of course, looking at beyond that, it's no secret that lots of countries are experimenting with the full kind of connected life, starting from your home into your city and into, which has an impact, of course, on your healthcare and brings all that together in terms of level of connectedness. And again, we've seen that a lot of these technologies and a lot has been presented in this event in terms of the technology is actually here, but how do we actually bring it together and make it work for the better of the population at large and the patients more specifically. So we've seen obviously the surge in terms of virtual care using videos and using kind of video consultations and so on and so forth, the wearables and the sensors, as my colleague has mentioned earlier, diagnosis using the AI agents, obviously the connected homes with all the wealth of data in terms of how do we track in our own environment, whether be it the home or the city, and so on and so forth. So bringing all of that kind of technology to help us basically move forward with better health outcomes. Now, we've looked actually when it comes to artificial intelligence, we've looked at a number of things in terms of what are the real use cases that we could utilize across the healthcare continuum, starting, as we said, from well-being, prevention, looking more into the patient experience itself, and as Klaus mentioned, actually more self-care, so looking after yourself, being aware of your condition, having the information at your fingertips when you need it and whichever time you need it. We very often refer to the syndrome in healthcare, the white coat syndrome. So, i.e., your healthcare only stops as soon as you leave the hospital or leave the environment where you actually receive the care, more into kind of your surrounding, your own environment, and actually being able to be in control and fully activated and empowered to basically look after yourself and understand exactly what are the implications of some of the decisions that you make in your daily life. Moving into diagnosis, clinical support, as we said, the care delivery itself, and making every aspect of care delivery evidence-based, with targeted plans, with more personalized, as we heard, not one size fits all, but a care plan that actually answers the actual questions and the concerns of the individual, as opposed to a generic kind of way of dealing with things. On the administrative activities side of things, we hear so many doctors and clinicians being fatigued by the level of administration that they have to do. So taking that away and actually automating those mundane activities like revenue cycle management, claims processing, clinical documentation itself, intelligent coding, and so on and so forth. I think all of those aspects will have much better impact in terms of freeing very valuable resources that have taken time, a very long time, to be certified and become specialists in their own area to do what they do best, which is focus on the patient themselves and take that stuff away from them using the automation and the AI. In the public health space, we've heard from many speakers as well, again, in terms of predictive analytics, understanding where is my population or my cohort is actually heading to, what are the interventions and the screening activities that I need to do in order to prevent this, knowing what we know about the population by looking at all the data as well, not just from a clinical perspective, but enriching it from other aspects of our lives. So again, the use case or the case for AI and for automation is definitely here. I think the problem is really making that mainstream and bringing it more into this center and the forefront of how we deliver care. I won't dwell too much on this slide, but again, we've looked at a number of use cases specifically from a clinical perspective, looking at diabetes, maternity, cardiology, urgent care, oncology, mental health, and so on and so forth, and looking at what are the kind of approved solutions or approved methods today that are using some of these digital technologies and AIs that have actually been certified and approved either by FDA or by regulators around the world. And the list is large. And again, the problem here is not the solutions, but actually adopting those and actually making them mainstream in our healthcare system. Looking at the automation itself, as I mentioned, there is a lot of things that have been done in this space, perhaps not as much in the healthcare sector as it is in banking, for example, in transport and other aspects. Looking at kind of perhaps the mundane aspects of the healthcare system and automating those and taking away the very valuable time of our clinicians and administrators and focusing them on more productive activities and more things that will influence and impact the population at large and the patients specifically. So anything from improving revenue cycle management function, patient scheduling and triaging. We've seen patient flow being directed through the hospital based on the load, based on the availability of clinicians, based on many aspects, and taking kind of that away from just a human person that just sits there and tries to figure out where does the patient move next, or how do I move my people from emergency department to different departments within the hospital, and so on and so forth. Claims management in general for those who have insurance-based systems. How do we make those more streamlined and available and more efficient, all the way to managing inventory, digitizing patient files, and so on and so forth. So I think the story is definitely very strong and it's building over time, and there is a lot of usage that we can do from automation and AIs. I think there isn't one talk nowadays that doesn't kind of delve into the impact, of course, of COVID on any industry, and obviously healthcare is at the center of that. And we've seen, as some of the speakers have mentioned, a huge, massive acceleration of using digital technologies because of COVID. Just a very simple example, in one of the countries where I live in the Middle East, they've had a video consultation solution for many years. It only was seeing around 10,000 consultations per year. And within the first month of COVID, that number went to 2 million just in 1 month. So an exponential increase in terms of usage of those sorts of solutions. And that tells us a lot about, when we're forced and we're cornered into and we have our backs to the wall, we think innovatively and we think more about how can we utilize what we have and actually deliver good healthcare to people. So I think I'll just stop here. I know we're slightly over time, but I'll leave you with this particular slide in terms of the overall aspect of how various parts of automation and AI has been able to help at the heart and the forefront of the pandemic, whether be it from a drugs discovery, from a crisis management, from health and risk impact assessments, from speed of prediction and tracking, all the way to actually screening and understanding, the trends within the illness or the pandemic, and where are the kind of next transmissions going to happen. With that, I'd like to thank you and hand back to the chair.
Thank you, Yad. And that was really informative. And so, Angana, do we have time for a few questions? I know that some questions have come in the chat. So I know it's also 6 o'clock. I don't know whether there are other sessions after this. So do we have time for some questions? We can't hear you, Amara, in case you're speaking.
Speakers of the other sessions have joined. If it is all right, Rupok Boro, you're chairing the next session. Can we take up few questions very quickly?
Yes, you can continue, Sulabna. I mean, this can take, otherwise, or maybe for 10 minutes.
Okay, we'll do that. Thank you, Mr. Bora. So I think I would probably just go ahead with a few questions which we have, sort of come to, which have been posted. One of the questions is, the devices play an increasingly central role in monitoring and supporting, healthy habits and, overall remote monitoring of health, but they also pose significant data privacy risks for users. Any views around this? Yes, Klaus, you can.
Yeah, I would like to. I'm one of the users, and for sure. So I think it's about ethics, and we have very good and very interesting from about the ethics in AI. What I think is we need to learn to respect our privacy. I think one of the bad things of COVID is that all the things we have reached in terms of securing data privacy has technically been set 20 years back, something in regulatory wise. And I think we need to fight back that part. And I think it's important because it's about creating trust. If people lose trust, if you lose trust in a currency and a government, it's bad. If you lose trust in data, it's also bad for AI and healthcare, for everything. So one of the initiatives I'm working with is the Data for Good Foundation. It's only about creating back trust in that we can share data and handle it. The European Commission has played a pivotal role in trying to establish a new way of battling this kind of thinking consumers as a product, and I think it's a bad way. And I think Apple now clearly shows another way of dealing with this. I hope this is a thing that governments will tend to think about, because if we will not share data and people will find other ways. You see how now I'm in Asia, I can see how people in Hong Kong and the Tea Party is moving around with finding other ways of sharing their data. And it couldn't happen in healthcare. So I think it's something we have to really, really take seriously, this concern. And I'm working on a model how to use technology to claim trust using a blockchain. I think that's where we can find some of the answers.
Can I attempt that answer?
Thank you, Claude. Yeah. Yes, please. Go ahead.
Yeah, the other aspect to this is, of course, with the kind of the data that we have, Klaus, you talked about multi-party computing. There are a couple of terms which are going to be heard more and more often. One is, of course, what we call as the homomorphic encryption, and the second is the differential privacy. It's my intent to introduce both of this term in terms of scalability that we are seeing with lots of people across the different world sharing the data, or even keeping the data within themselves, but sharing the algorithms that they produce to actually go and look into different geographical and ethnic population. And we're seeing more and more of it with the help of homomorphic encryption, where you do not need to actually decode the data or decrypt the data before you actually run the computation on it. And differential privacy is actually doing the computation without using any one of the PHIs, 18 PHIs that we know. So when these becomes relevant, the questions related to devices, data, and how they are handled over a period of time is going to go away.
Thank you, Sridhar. Sridhar, there was another question that how does penetration testing help? So maybe in the same line, you just...
Yeah, so I already answered that question in the chat box. So it's a helpful tool. If you're looking at it from the perspective of risk assessment and looking at if you are identifying vulnerabilities in the system, and if you want to look at also what are the strengths of your mitigation strategies. It also gives you a good quantitative and quantitative estimation, helps you to allocate budget and put in right people at right places to do the work.
Thank you. So I think in the interest of time, I know that we've already, at 6:08 and the next group is waiting. So I would probably suggest, Angana, if we can probably publish the email IDs of these speakers after taking their consent, so that the viewers can probably send in the questions individually. And with that, I would probably just give the control back to you, Angana. Thanks to each of the speakers for such an insightful, discourse. It was quite informative for many of us, and I'm sure the audience would have really benefited out of it. We would try and also check with the speakers if some of the presentations they have shown us, if they want to share that on the Bengal Chamber website after, obviously giving the versions which they're comfortable with, we will try and share that as well. And along with that, we'll try and give their contact email so viewers can probably reach out to them individually if they want to. Thank you once again to all of you. And with that, I'm going to back to you.
Thank you. Thank you, everyone. So we are moving on to the next session, that is users' experience of technology for cloud streaming. The session is continuing. I would request the Facebook audience, we will relive it in a couple of minutes. So we will just take a couple of minutes to relive it. So we have with us Mr. Rupak Borua, Group CEO, MRI Hospitals, who is chairing the session. And in panel, we have Mr. Rajiv Sikka, CIO, Technology Leadership and Program Execution, Medanta, the Medicity Hospital, Dr. Soumitra Varadwaj, President, Medica Super Specialty Hospital, Mr. Partho De, Founder, CEO, U4RAD Technologies and Director, PAS Digital. We are expecting him? He has joined. Thank you. So Mr. JP Divedi, Chief Information Officer, Rajiv Gandhi Cancer Institute and Research Center, and Mr. Suresh Ramu, Co-Founder and Director, SiteSpace Research Private Limited. Mr. Borua, I would request you to allow us a couple of minutes. We are just reliving for the Facebook audience, and we'll give you a heads up in maybe 1 or 2 minutes when you can start your panel.
Sure. During this COVID situation, we could understand what is the importance of the digitizations. Now, thanks to technology, there's the patients get better treatment now with virtual reality tools, wearable medical devices, telehealth, and 5G mobile technology. These are all there, and doctors, on the other hand, can streamline their workflows using artificial intelligence. That is the artificial intelligence power system. So that is the whole part of the digitization that took place. If we see, there are a couple of areas where the digitizations are more working. There is one part that we can see the rise on demand healthcare, why a patient want healthcare on their own schedule. That is 52% of all web browsing the world occurs on mobile devices, that we have seen 2.7 billion actually people worldwide weighing this your smartphones, and 77% of the customers, they prefer going online to book medical appointments online. That is one part. The second part, if we see the development of the digitization, how it took place, that is the importance of big data in healthcare. We are expecting that maybe this big data will surely giving us a lot of impact on this your lower rate of medication errors. This maybe facilitating preventive care. There is a more accurate staffing that the hospitals, they can make it. And physicians and hospitals need big data because the 47% of healthcare organizations are already using patient data predictive analysis. That already they have started doing. And 57% of healthcare companies think predictive analysis will save them 25% of this year. Every CAGR will be 25% growth they are expecting, and will be reaching 14.9 billion by 2025. So further that the big data is concerned. There is a growth in this year treating patients with virtual reality that has taken place. That is, the virtual reality helps doctors get better training, one part, and the medical virtual reality market will reach $51 billion by 2025. And these virtual realizations can reduce post-surgical wound and pain by 25%. That is the prediction. Now there is one part also that is tremendously growing. That is the growth of wearable medical devices. That is the 44% of the people all over the world that has been seen. That is they prefer to wear wearable devices, and 84% of the consumers, they are still maintaining the major data out of their wearable devices. There is one part also that is we are talking about that the wonders of the artificial intelligence, which has been hugely growing in the healthcare space. That is 84% of the industry leader, if you are talking about that, they are thinking, the leaders all over the world, now they are thinking that artificial intelligence will soon transform healthcare. And it is also, there is a market we are expecting, maybe it's a 34 billion by 2025. So you see that whatever we are talking about, the digital or the digitizations or the technology, how healthcare is tremendously growing and taking the technology in their hand. So having said that, having said this perspective, I would like to discuss some points with my eminent speakers. So first of all, I would like to ask Mr. Rajiv Sikka, who is heading this year the technology part of Medanta Hospital, one of the largest hospital that we all know Medanta, how Medanta is doing. So there is one thing I would like to ask you, Dr. Mr. Sikka, that is, so what was your experience, this digital initiative implemented in your organization, particularly during COVID time, and what you are planning to do the post-COVID time? So if you can share your experience with the audience, that will be a great learning session.
Sure, sir. Thank you. Feel very happy to be part of the panel, and some of the panel members are very, very good professional friends. So thanks. So when you talk about COVID, I think the story is not completed unless you say so about telemedicine. So we were running a telemedicine platform for roughly 4 years. I think roughly 4 years plus now. And this telemedicine platform was not a typical Zoom or a video call platform. It was a very well integrated platform which was talking to 7-8 platforms in the back, which includes tariffs, doctors, their appointment slots, their EHR, and their availability, and so on and so forth. And definitely the payment gateways. So pre-COVID, somewhere in February, March, our volumes were roughly less than 40, 50 consults per day. I'm talking about February of 2020. And by September, we were easily doing 600 plus consults per day. So that's the roughly 12 times jump in 8 months in the telemedicine. And I'll share some examples that we were having some myths about telemedicine platform, that it is only, youngsters stuff. We realized that more than 55% of the people who are using telemedicine platform were 50 years and elder. We realized that it is no more a city phenomena. More than 45% of the people who were using, the patients who were using telemedicine platform were coming from UP and Bihar and Jharkhand. And generally these states in the country have this perception that they are lower in the usage of tech. Third thing, which was that only chronic disease patient will never use this platform. They have to come to hospital. And we realized that onco, neuro were the topmost specialties which were using this platform. Fourth thing which we realized is that new patient will never come to the telemedicine platform. Only the one which are old patient are captive and they have no choice but to use platform. We realized that more than 45% of the patient registered in the telemedicine platform in last 7-8 months were purely new patients. So this is one learning, and we realized that one more stuff which we just want to share is that in Delhi, government announced that COVID can be taken care at home, which means that if you can manage the patient away from the hospital, which is the future according to us of healthcare in India. We have to have patients being taken care, and they don't have to be in the hospital. And within 48 hours of launching that program by the Delhi state government, we launch our own program for taking care of COVID patient away from the hospitals. And in roughly 5-6 months of span, we treated more than 10,000 patients at home. They never visited Medanta. Okay, so there was a daily monitoring call. They were feeding their vitals on a typical app or browser, and we were getting those alerts, and doctors or nurses calling them, so and so forth. So this one solid learning for us is that a lot of chronic disease patients which never or which generally misses their routine consults or diagnosis can be managed away from the hospital. And we did this program. Now Tiger has tasted the blood, and we will not eat the grass. What it means is that now we have started applying the same principle on chronic disease management, especially in the endocrinology department. And some of the programs which we have launched are super success, which means patient don't have to come to the hospital for a typical day-to-day or routine monitoring. So this is the third learning. One more stuff which we realize is that to manage CT and MRIs, you need senior technicians to place the modality when the patient is on the table. And we realize that those senior technicians are also exposed to COVID. And can we do this management away from the hospital? And just imagine that we started doing it. And this is not required for a typical CT or a typical MRI. This is required only for specialized stuff, and the patient has to be laid on a certain fashion. And now our roster is so easy. So whenever once a special case comes, my senior technician doesn't have to rush to the hospital. He's wherever he is. He has a laptop at disposal. He remotely manages the modalities. So what I'm saying is that teleradiology, telelab, telemedicine, managing chronic disease management, all of these stuff are super learning. And I would say that tech is the unsung hero in the COVID era as far as the healthcare is concerned. So and some of these learnings we are definitely applying, not just we, I think all of the hospitals are applying, and that's, according to me, is the biggest learning of COVID for hospitals, including Medanta. Sir.
Thank you, Mr. Sikka, for giving the insight of this, how you could manage this, your COVID-19 situation particularly. See, one thing that we can see that despite the many devastating impacts of the COVID-19 crisis, it does present that healthcare sector with a powerful opportunity to innovate at a very quicker pace and in some ways reinvent itself. That is the major part that we have learned out of this COVID situation. So thank you so much, Mr. Sikka. Now I would like to ask Mr. Dwivedi Mr. Dwivedi, you are also heading the technology part of a large organization, but you are managing a very particular kind of a specialized disease, the oncology care. And during this your COVID time, we could see that you will have to maintain the treatment protocol, because there are the oncology patients, their continuation is there, and you'll have to continue. There is no question that during this COVID that you can stop the treatment or you can convert this as a COVID hospital. So in this kind of a volatile situation, how you could manage your organization? You could keep your patients safe, the employees safe. So how you could manage? What was your experience?
Sure. So Medanta was way ahead in the curve. They were working on telemedicine solutions long before COVID actually came to the fore. We were not prepared. So when COVID came, we literally started with whatever was available, and very platforms that Rajiv was telling, using Cisco WebEx and just making the patients pay on the website using a standard payment gateway. But within 2 months, we came with the app and that was fully integrated with our hospital information system. And we enabled our patients to actually book their appointments online on the app, register themselves, giving minimum information, and see all their lab and radiology reports, prescriptions even, and we enabled online payment using app, and also facilitated the video consult from the doctor to patient directly. Of course, we appointed a few telemedicine coordinators who will come in between, because, in spite of best efforts, sometimes doctors may not be available for teleconsult at the designated time. And this is our experience. So they needed to be second checked. So of course, some human intervention is needed. Patient will show the inclination to consult a doctor on a particular day. That particular interest will come to the system. The coordinator will check with the doctor, and once doctor confirms, then only payment link will be enabled. So there is no dissatisfaction and there is no undue expectation. Once payment link is enabled, everything is all set, and at the time of the scheduled call, the coordinator will call the patient again, and doctor is waiting in the OPD. And the waiting list, there is a single integrated waiting list. So that shows the patients who are really outside the door of the doctor and the patients who are waiting over the telemedicine platform with some specific link that this particular appointment is for telemedicine. Doctor just has to click and the video session opens. The consultation happens. Doctor can make online prescription, and the prescription reaches to the patient through that app itself. The patient can take the medicines, treatment, and go for the investigations as are required. Subsequently, patient can either do a follow-up over telemedicine or can physically come. Of course, there are certain limitations in oncology. You see, chemotherapy cannot be administered remotely. So for such interventions, whether it is chemotherapy, or it is radiation therapy, or there is a surgery required, those visits are mandatory, but at least post-surgery follow-up visits, post-chemotherapy, there are a lot of questions, lot of queries that patients have, lot of post-treatment morbidities are there. At least those unnecessary visits can effectively be avoided. So that is where we stand today. Our platform is all being appreciated by our patients. And as Rajiv's experience says, the old patients and patients who don't understand ABCD of technology, even they have their children, their relatives, somebody is there to assist them, and they are very happy and blessing us.
Yeah. Thank you, Mr. Dwivedi. So we could understand that during this your COVID unprecedented situation, actually, this how we all utilize this your technology to mitigate the demand, and this the safety side of the patient, and that they should not come to the hospital, they should visit the hospital through remotely. So many ways we could see that we have taken the help and the support of the technology to overcome the situation. So that is one very big part. Now I would like to ask Mr. Partho De. Partho, you have a lot of your exposure in terms of your managing a healthcare, and also you have developed so many different kind of technology tools during your past, and also you are now developing at present as well. So I would like to ask you one thing that is a consumer specific. In case of consumer, in case of us, it is a patient. So if you can say the patient specific initiatives using your digital technology, particularly in healthcare. So what are they doing, and what is the future of this? Can you please give us some kind of an insight of this particular space?
Yeah, thank you, Rupakda, and it's an excellent opportunity to speak on this topic. Specifically to the point of a consumer, we often miss it. Most of the time, our hospital digital initiatives are targeted to the clinicians and certain time to the administrative people of the hospitals. We do have a lot of proliferations of telemedicine as of now, but that is more towards looking at how you are availing a medical services through the internet-enabled world. I thought of bringing a different perspective over here, is talking about how we are taking the consumer initiatives in the hospital when the patients are being admitted there, and how we are in a position to offer them better services from a service delivery perspective. Let's say if a patient is staying with us as an inpatient, is there any way we can work out some situations, some platform, some technology enablement through which the service quality what he gets may not be limited to the clinical service quality, but to a non-clinical service quality, because in a hospital stay, the patients would often require a good quantum of a non-clinical services, and how we can help over there. Very simple example is that if a patient need water and the patient is admitted in the room, typically what they have access to is a nurse call bell. They would be pressing the nurse call bell and somebody would go and then probably help with that. And we have seen most of the time the nurses will go and then they will understand the water is required and they will send someone else with water. And this is a nurse's visit is completely wasted for that case. So what we have done during this time is we have developed certain systems through which a service request can be generated, either using a voice command, like the way they will speak, maybe using a Google Talk type of situations, or maybe by selecting a specific services, the patient should be able to put up a service request, and the service request could be as simple as I need water, or it could be something else like I'm going home and can you book a cab for me, or could be any other services when they are staying inside the hospital. And this service request could be will be completely tracked, and the patients would know when this is going to be fulfilled. The challenge with this non-clinical service request in the hospital is they don't get tracked. Particularly clinical services are tracked either manually or electronically. Most or no hospital would track non-clinical services of the patient, but they are very important from a patient perspective. If a patient would like to go to the toilet and there is no one to help him, this is a very difficult situation, and then we have seen several times patients fall because patients has tried to use the toilet of their own. So that's a platform that I have worked with, and the platform now is in a position to help on a non-clinical service delivery with a complete follow-up, and hopefully this is going to elevate the customer experience completely in a different level while they're staying over there. So that's one of the examples that we're looking at. The other area, again, from a consumer experience perspective, what I'm very fortunate to share that we could be able to work out is related to the visitors management in the hospital. Now, visitors are a very important element in the hospital. I'm talking about the visitors who are visiting patients in the hospitals. And visitors would typically visit the patients, and more often they would like to understand the patient condition from the care team. And that's a challenging area. So there are times when I call Rupak Burwa
as my Dada and said that, Dada, can you please help me with a patient condition in the hospital? Fortunately, I may know some of the healthcare professionals and I can get the information out. But otherwise, if I don't know anyone, irrespective of the patient is getting best of the services in the hospital, patient relatives typically may not be aware of the services being delivered to the hospital, both clinically and non-clinically. And there are times we have got patient feedback that the patient said that, well, everything was fine, but we were in dark. And is there any way you guys can communicate with us better? So we thought that can we use technology platform to manage this visitors area of the hospital completely as a differentiated customer experiences on a platform where a visitor would like to talk through a e-visit or a virtual visit, can schedule a visit either with a care team, and they could be able to choose whether I want to talk to the nurse, physiotherapist, dietitians, or the consulting doctor or the RMO on duty on a particular time, rather than trying to reach out at any time they want to reach, on a scheduled basis, and also book a visit with the patient if the patient is in a condition to talk to them. If the patient is in an ICU and other situations, or not in a position to talk, the other care provider team members can carry a phone or a tab and then get the patient and their visitors to talk to. So that's a more a virtual patients visitor management solutions that we have worked out. That definitely has helped a lot of people. Because of COVID, we have restricted access, and rightly so, as much as possible. And also to do with the physical visitor management. Whenever visitors are coming to the hospital, we do typically use a card, and the card has to be exchanged between various people. And we wanted to have a contactless visiting management situation where a QR code is being sent once the patient is admitted in the patient's mobile phone, and that QR code could be scanned, and then the patient can be entered or admitted. Patient visitors are entered over there in the particular room. We all understand that because of the large size of the hospital, it's really difficult to find that exact place. And here, the patient gives either a wayfinder completely telling that, okay, how he has to reach to the patient room at what time and when he is expected to see the patient. So these are the two examples I thought I will share with you, which is completely towards the consumer-facing experience and trying to create a differentiated service experience for the patient, considering them as consumer.
Right. Right. Thank you, Partha, for your very interesting solution you have created, and trying to sort it out with directly with the consumer, which is one of the most important parts. Sometimes we, that we neglect them in many ways sometimes, but which is very important, and is in the process of your delivering of your healthcare, which is they are part of the program. And it is very important for all of us to create a kind of a business model with participating their part as well. So thank you, Partha. Now I would like to go to Soumitra Bharadwaj. You are handling many the operational issues in your hospital. And we have observed also that during this your pandemic time, unprecedented time, you have handled thousands of patients. You are one of the highest number of patients that you have handled, and in very, very challenging scenario. So would like to understand a little bit of your experience as well. This is a sudden outburst of this your pandemic situation. So how you could handle, and in various ways, maybe in the service front, the clinical part. So how you could manage the show actually during this pandemic time, and what is your plan way forward?
And way forward. First of all, good evening to everyone. I'm very happy to be here. Good to see some of my colleagues on the panel. Hello to everyone. Regarding your questions, sir, of course, these were unprecedented times. And we were not prepared, and most of the thinking was done on the trot. We came out with innovations from the learnings and feedbacks from patients. To begin with, the biggest challenge was that the old system just came crumbling down. First challenge, infected patients coming in, family not interested to get him inside the hospital. So transport in of the patient was our first challenge. training people into doing that, yes. But even when we were inside the hospital, two big challenges which we faced. One was rounding. I think where technology played a very big role. Simplified solutions, the jugaad of Indian civilization and mentality played a big role in our initial rounding. So we had telemedicine inside our hospital as well. So while we talked about Sikha Saab very rightly gave us a complete fantastic insight into the telemedicine for outside patients. But we used it even for inside the hospital between doctors and between patient registrars, RMO and doctors. Because sir, what we realized that the most valuable people in the city were our doctor force and our clinical force. So the first biggest challenge used to be one of safeguarding their health, because we were fully aware that the biggest source of infection would be the hospital. And in that we used telemedicine in a very big way. Computer on wheels played one of the biggest roles in keeping our healthcare team healthy, fighting and kicking. This was one thing. Second, as Partha rightly said, the communication between family and patient became a big challenge. The whole society was engaged. Every person came through 4 or 5 channels asking about the same patient. It became a little bit of an insane flow of information from various quarters. And I would say there was an element of Chinese whispers. The only way forward was to create one person contact, which created further problems. Legality required that the next of kin would be the contact person, and many a times next of kin didn't have the knowledge or the sense to fully understand medical situations. And as patient deteriorated, we were confronted with many serious allegations about communication, lack of health, which had even medical legal implications. What really saved us was that each and every communication was recorded. Each and every communication was recorded. And we kept a backup and a library. Given the fact that we were at one time handling 200, 220, 230, 240 patients with 11, 12 patients on ECMO, another 40 on ventilator, it became very crucial for us to create a audio video library. There was no place for paperwork. This was something we did well, and I, being also head of marketing for my flagship hospital, was saved many a times when complaints happened. So I would say that from now on, the biggest learning is keep all communications on our audio-visual file. I think paperwork is now past. That is something which we all need to take care of moving forward. About learnings, I think something which became also a big problem was doctor time management, for which we created 3 layers of doctors, communication systems, which worked very well. The biggest learning, I would say, going forward would be that tech, which got very cleverly and nicely energized. Like I would say, COVID was for telemedicine, the demonetization of electronic payment gateways. We need to nurture it. We feel that the doctor's part of telemedicine should be made as comfortable as possible. I fully agree with Partha that a patient user interface is usually neglected, and his suggestion about those patient experience have to be given priority. But telemedicine, if it has to survive, it has to be properly managed. A department and a team has to be introduced so that the doctor's time in telemedicine is least possible. So that's something we could talk later, but from my point of view, what I've told in my hospital, that a separate team of 4 or 5 people need to be introduced right away to sustain the telemedicine initiative for the sake of better healthcare systems of the future. Thank you, sir.
Yeah. Thanks, Soumitra, for your very right kind of an approach, that the documentation in this kind of a digital era is very, very important to avoid any kind of medical legal issues, and not through your the paper part that is all past. So we'll have to move forward with a fully digital way, how the hospital can keep all kind of a documentation of the materials. That is very, very important in today's situation. So I would like to go to Mr. Suresh Ramu. I think Suresh Ramu, Mr. Ramu, you are here, no?
Yes, absolutely.
Yeah, fine. Thank you. So, Mr. Ramu, that is considering your background and all we are talking, you could see that all the service providers, they are all talking about manifold increase of the digital platform technology. Using technology, there's 150 to 200% of increase of the digital platform. And from your background, I would like to ask a very important question. That is, you know that these digital platforms are what we are talking about, from 50 teleconsultations to reached out to 600, 700 teleconsultation. And these are the teleconsultations and all this digital media we are talking about, big data. So these are all a very vulnerable kind of a data. And these patients, they are sharing their very, very confidential data on the platform. So from your side, we would like to ask one thing. This is a security and privacy in the digital health era. How you look at that, and what kind of your experience or suggestions you can give all of us so that we learn something out of that.
Sure. Thank you so much to all of you on the panel, Dr. Rupak Barua as well as the Bengal Chamber of Commerce. See, I just a little bit of background. I was part of a telemedicine startup about 21 years ago. Obviously, the wrong time to do telemedicine when there was no broadband network. And when we're talking about telemedicine not working just 4 years ago, obviously 20 years ago was absolutely incorrect. But it gave me a significant grounding into the challenges in healthcare. I stuck to healthcare research subsequently for the next 20 years. And in the last 6 years, we've been part of a cancer hospital project called SiteCare Hospitals. So I run a cancer hospital now, and I've also been part of clinical research. And I have a slightly of a technology background. So to come back to your question, I see that 2 or 3 challenges. Number one is that if I look at it purely from a cancer play perspective, and Mr. Dwivedi already mentioned that there is a continuum of care in the whole cancer care journey, for example, that you need to worry about. From a patient perspective, when there is no availability of or access to a clinician, or there is no way to reach the hospital, I think they are looking at any possible means that are available to reach the clinician. So from their perspective, actually, though they do have concerns about data privacy and security, I think their primary concern kind of becomes access. Once there is access, and once that becomes standard of care, which is beginning to happen, at least in some types of follow-through treatment, then I think obviously there is a question about, is this channel of conversation secure? Am I talking to a clinician on the other side who I know is the clinician that I want to talk to? Is the advice that I'm getting coming from the same clinician that I'm talking to? Because in a face-to-face environment, you have trust that is set up because of the physical channels that are available. In a virtual environment, you can change the background, you can change a lot of things. So, and if the video is not switched on, as was mentioned earlier by Mr. Soumitra, it can become a significant challenge as to know who is on either side. And the doctors also don't want to speak to somebody who's not the patient, and they want to know if they are talking to the patient or the direct first in charge of the patient. So I think the trust becomes the first part of the communication channel. And then you're talking about privacy in terms of making sure that this channel that was established is private and secure in the sense that it's happening between the two intended parties. And the third is, of course, then is there integrity? Is it being stored securely? Can it be accessed by anybody else? What are the medical legal implications if accessed in out of context, for example? As we know, in medical healthcare, you can take things out of context, and then there's a lot of misinterpretation that is possible. So an example of this was when we established a tele-ICU setup. And I think tele-ICUs have been a concept for a long period of time, and it was largely driven, and even today when I speak to many healthcare administrators, the concept of tele-ICUs is applicable when you don't have, let's say, intensivists, or you say you don't have the workload, or you feel that there is a cost optimization that is possible. However, our experience has been that it completely upgrades the quality of services that you can do. For example, you can have a full-term team on site, but you can have a team that is remotely monitoring and capturing all the data and the vitals and trend lines as a second layer of quality control. So you want this channel to be secure, obviously. You also want this channel to be managed securely, and you want the data to go into the specific health record of that individual and patient. And you're talking about an ICU situation, so obviously you're very concerned about how the care is delivered and what are the medical legal implications of this. But the biggest benefit is the fact that you can do continuous monitoring of data, and that you are recording it, and that you have now enhanced monitoring, because you're not just dependent on the nurse or the intensivist on site. You've actually upgraded the entire level of care that you're able to provide to your patients. And I think, so while operational efficiencies are extremely important, and several examples are there in terms of how technology has helped bring in efficiency, but I think a very fundamental requirement that we need to talk about is delivery of clinical care and upgrade of clinical care itself through the use of technology. And when we talk about core clinical solutions, the very question that you asked about data privacy and security become even more critical and important. In operational efficiency parameters, people are willing to sacrifice a lot of that. People are okay, if you're, for example, in many hospitals today, the name is called out of the person, and there are 20 people sitting in the waiting area, and what is the privacy, right? You're talking about the name of the patient being called out in front of 20 people. In some hospitals, you would have a token, and you don't know who is the token, so there is some level of privacy that you can assert. And you don't need extraordinary technology for this, but the principle of privacy becomes important. When you walk into a floor in many hospitals, you have boards that proudly or list out the names of the patients in the various rooms. Now there is no privacy because you're displaying the names of the patients to all visitors, at least in that floor. And there are many who have implemented private solutions to avoid that, right? So in the context of what we are looking for, or maybe in the local context even more so, I think privacy needs to be very, very carefully defined. I think India is maturing. India has definitely got its privacy laws, and I think there are definite requirements in terms of how we manage and store the data. The HIS systems and the EMR systems are definitely getting upgraded, but there are significant gaps. And we evaluated our system about 4 years ago, and we're continuously evaluating for an upgrade now. And I must tell you, I was speaking to several administrators in a recent meeting, and there are over maybe 30 or 40, some of them have evaluated. And there are significant challenges in terms of the functionality that you want to seek. And then you go on to describe what is the security standards. Are there significant audit trails, so that how the data can be manipulated or not? Because these are the questions that are going to come up as technology adoption becomes increasingly important. So I think there are several takeaways on the side, but for administrators, I would say put it right up front in terms of the needs for how you store the data, how the data remains secure, how you can access it. What if scenarios in terms of whether the platform is exclusively available within the system, and then you have those limitations of upgrades, etc. But you have the security that it is at least within your secure environment. But storage can become a challenge. If you're going to store it on an Amazon-like cloud, then you also have the same challenges that you would with any other service provider. So these are, I think, the primary challenges that the Indian healthcare is going through right now. And we are, I think, seeing more maturing of these systems, but we still have a fair bit to go. I think the critical component that I would say that does not drive our healthcare delivery is who pays for healthcare. And I think that makes the whole difference between why you can see adoption of technology at a far greater pace in many other countries versus India, because a consumer or a patient and a family, when it's self-pay, wants to make it as affordable and accessible, and they don't really want to, they think everything else is frills in this whole delivery system, while they could be absolutely core in a purely clinical context.
Right, Mr. Ramu. That is absolutely rightly you have pointed out the present situation in terms of your safety, security of the vulnerable, the data which we are keeping, and there are some ideas of this your eICU and all. So that is a way forward. Now I would like to, because I think Mr. Sikka would like to go for another web session. So I would like to finish with Mr. Sikka one point. Would like to understand, because you are managing a large, as I had mentioned, and you have done so many, that initiatives you have taken during your the pandemic situation and all. Would like to ask you one your way forward. I mean, what are the innovations you are considering? See, why I'm asking this one, see, the healthcare needs more of disruptive innovation. Though there is a great opportunity, we can see that is we have innovated in many ways within a very short span of time. There is now people are talking about now that we need to reduce the cost, because there is a finite part of this your expense part that we need to control cost, but we cannot compromise quality. Here, I think there is a digital technology plays one of the major roles. So in terms of your initiatives, this cost and quality, so they improve quality and reduce cost. So now people are in the Western side, people are talking about more of the value agenda, where you can measure quality, what are the kind of your treatment is taking place, or your investigations that doctors are prescribing. It is not necessarily that it is more investigation, the treatment will be better. So how can we can control the cost, we can measure the quality. So are you thinking of any way that you are trying to deliver something for your doctors and all, where you can measure quality and you can reduce the cost as well, controlling the cost?
Sure, sir. There are two major areas in which we are thinking about these two aspects. One area is on the service excellence part, the example which Partha took, and the other is on the clinical outcome part. So let me focus on the clinical outcome part. Partha took some very precise examples, and I'll share. But let's focus for time being on the clinical outcome part. See, in Medanta, we do roughly 1,000 odd radiology tests per day. When I say 1,000 odd, it includes X-rays, CT, MRIs, PET CTs, DEXA included, mainly on the radiology side. And out of which roughly 60% are around X-rays, both in the OP and IP, and definitely in the ER. And what we realize is that these X-rays are always getting reported, in a delayed fashion. Simple reason is that, a lot of senior radiologists don't want to do X-ray reporting. We all know the subject. In IT parlance, a software programmer will never like to do a testing. This, I have learned in my 30 years of career that if you do, send a programmer for doing a software testing will never be good. Same theory is there with the senior radiologist, he will not do the X-rays. So we are realizing that X-rays were getting delayed in reporting. One more stuff which we carry out, sir, is that we run India's largest TB-free Haryana program, where our van goes to districts and small areas, and they, we at any given time we do roughly between 180 to 200 20 odd X-rays per day in the van, which is a remote area, and we have only one radiologist. So what we realized is that this is not working out. So recently, we went live with a software on the AI for X-ray reporting, and this POC was going on for roughly 8-9 months, where we did POC for more than 3,200 odd X-rays in a one-side blind study, where algorithm was not aware of what the report doctors have given versus the algorithm is giving. So we realized that, and slowly we started calibrating those software, and now the precision is almost 99.3% in chest X-ray. So what we have started doing is that as soon as the chest X-ray is out, software gives you a report which comes to the clinician and radiologist, and radiologist has the report along with the annotation on the packs stating what are the abnormalities and what is the report looking like. In case radiologist feel that this is right, he simply says submit. In case he feels that no, I have to do minor changes here and there, he definitely, it's the subjectivity of the clinician and radiologist, he does that changes. And we realize that our X-ray reporting time on the chest side, which was roughly 2.5 hours, got reduced to roughly less than an hour. So, which is, it's still, not the desired TAT which we were looking for. We were looking for roughly half an hour or so, but still from 2.5 hours to less than an hour is fairly good stuff. So in this particular case, we were able to, save a lot of time of the senior radiologists who were devoting time on reporting X-ray. So saving of time, improvement, and in any case, we are aware of 99.3% accuracy on the chest X-ray, which we have proven with 3,200 odd X-rays in last 9 months. So this is one part. And I'm taking an example with on the service excellence part on the nursing. Sir, we all know that doctors are a rare commodity, but nurses are also rare. And we all know that in near future, probably nurses will be one reason where hospital can't function because they're in the shortage. So a lot of wastage is there in nursing time when they have to go for, giving a blanket or giving a water bottle or, saying that remote is not working in the TV. So we have done some work with Alexa. So we have Alexa in a room on the patient bedside, and we have Alexa on the nursing unit. So, patient speaks to Alexa, please arrange a, water bottle. So instead of, information goes to nurse. So instead of rushing back to press the nursing bell, nurse is aware that this particular call is for, F&B. Right now, we have not integrated F&B, we have not integrated housekeeping, but we will eventually do that. So which means that Alexa will figure it out, this call is for F&B, it will go directly to the F&B chamber. So we are working on that part, but this part has been resolved into 2 areas, and we did fantastically well in the COVID. This is also a learning from the COVID, where it was, staff or shortage, F&B guys were not willing to go, nurses were having difficulty in wearing those heavy, PP kit and traveling, all those issues were there. So again, I think we realized that this can be leveraged. We did a small POC on maximum leverage items, which were on F&B, housekeeping, and engineering stuff, apart from the clinical. Clinical is still catered by nurse, but these 3, in line with Partha's statement, are now done very, very successfully to reduce nursing effort in doing non-clinical work. Sir.
Right, Mr. Sikka. So we could understand that you are working on it out of the pandemic situation. You have learned, and more you are working on it. How value agenda can take place. That the digital contracts support you in terms of delivering value to the patient relatives, so that without any touch, without any working disturbance. So you can be more giving value addition to the nurses, where that they can focus on the clinical part only, and the rest of the part somebody can take care. So there is a more, you are creating some value in the organization. So that's, thank you, Mr. Sikka. Now, I would like to go to Mr. Trivedi. Mr. Trivedi, there is as we have discussed about that, there is artificial intelligence, and we all know that in the oncology care, there is a lot of use of artificial intelligence, particularly in this oncology segment. And can you please share us, maybe if not that the artificial intelligence per se, but if you can give us some kind of an example that we are, that so far the digitization part is concerned in clinical areas that you are working out, or maybe way forward. And one more thing also I would like to understand from you, that is, we all know that we are creating a lot of digital, that your apps and digital initiatives we are taking, but it's very difficult to penetrate or implement it to the senior consultants, doctors. They are not very tech savvy. So one way improvement is happening, your innovation is happening, you are trying to introduce many of the clinical areas is your digitizations, but again, there is an implementation part. So how are you managing your unit? So can you just give us some insight?
You have absolutely hit the nail. So yes, that is the challenge, and it is a well-known challenge. Initially, I also had this perception that actually the doctors are playing difficult. But we realized subsequently that was not the case. The software has to be, content rich, and it should reduce their effort and improve their clinical productivity. Then only doctors will feel happy to adopt it. We started with chemotherapy. We built the chemotherapy protocols with formulae and made it so simple that organ-specific list of protocols were there. Doctor just has to choose one, just put the height and weight, the BSA will be calculated, and dosage, etc., along with the entire list of drugs that is put in there, including antiemetic, antineoplastic, and maybe pre-hydration, post-hydration, flush. Everything is all fed, just depending upon that particular protocol. And maybe a resident can do it. There is a workflow. It goes to the senior consultant, doctor reviews it, and if there is any editing needed, doctor will edit. System also has a check for the patient safety point of view, that if the dose edited by the doctor is more than plus minus 5% of tolerance range, system will raise an alarm that this probably is too much for this patient or too less to be effective. Why do you want to do so? So there is an option to put a remark. Maybe there is a genuine reason. And the doctor says, okay. Now it goes to the clinical pharmacist. Doctor need not worry about, putting the dose and frequency and how much solution should be there, in what duration it should be administered. That is all well fed. These are generally the reasons why doctors are so afraid of using EMRs. Too many number of clicks, too much of data to enter. Obviously, anybody will get fed up. Here it is giving two advantages. One is that everything is on the platter, and second is it is actually providing additional patient safety. Third, doctor need not worry about the packaging also. So if patient needs 1250 milligram of gemcitabine based on the BSA, that is what the doctor will prescribe. Doctor will not care in what denomination that medicine is available. That is the pharmacist's job. So the complete workflow was designed, and I can tell you within 6 months, there was 95% plus adoption of this particular workflow. So my assumption that doctors are tough nuts to crack actually was proven absolutely wrong. Then we started working on the other areas, and we literally sat with doctors, because by this time we developed some credibility and some rapport with them, and these guys are worth something. So we did similar thing in the general OPD setup also, because every doctor has 5, 6 or 7 medicines generally as preferred list of medicines. Surgeons will prescribe certain antibiotics, certain vitamins. Those are there. We first covering, medical oncology, then the other two were easier. And then certain tests and certain order sets were built based on the doctor's specific practices. They don't see the whole plethora of things. They will see only that much of data. And it is very easy, tick, tick, tick. Everything, average adult dose, the frequency of the medicine, route, packaging, everything is all set. Even specific instructions, doctor can just edit. So this is the area that we could achieve so far. Now the next challenge that we faced is on the inpatient setup. When doctor is going for a round, doctor doesn't have that much time while, seeing the patient to enter clinical notes. Either on the tablet or on the cow, it is a real problem. So here AI can help, and we are exploring these solutions with a few potential partners. That one is maybe voice recognition. So doctor, clicks that particular app, patient is selected, and then doctor speaks, and notes are captured. Then doctor can review it maybe after completing the round, because enough data is captured now, doctor can edit and then submit the note. The other similar application could be the handwriting recognition. So maybe doctor scribbles something and then that is converted into text. It is now reviewed and probably saved there. Of course, the original sound file or the text file that was scribbled is also saved for the audit purpose. So in case there is a translation error, there is a transcription error, at least it is known that this is a technology error, original text is preserved. So this is the area that we are working on. Once we are able to completely crack it, I think it will be very easy and natural for our doctors to adopt EMR. Then third is the analytics part. So this is another complaint that generally doctors have, that we keep putting, nothing comes out. So we really need natural language processing. We need unstructured data processing tools, technology. So we are working with a partner that will give a real single longitudinal patient record, and that can show the patient journey in form of a beautiful dashboard. Can also do a lot of data selection and tabulation based on certain parameters, certain symptoms, certain diseases. This we are working on, and hopefully combined effort of these two will bring very fruitful results for us.
Thank you so much, Mr. Dwivedi, for your elaborate explanation of this, what kind of AI and how you are managing your senior consultant. It's a big challenge, and I'm very happy that you would understand that and you are managing that one very big way. So we are running a little short of time. So I would like to go to Soumitra. Soumitra would like to ask you one very simple thing, because we have talked about many value agenda. We have talked about innovations. We have talked about the new what are that we are doing. We have done during this pandemic, and what we are planning to do next way forward. One thing I would like to understand, very practical part. I would like to ask you that the digital part, digitizations part of the technology part, we will have to use it in terms of managing. So far we have talked about our stakeholders, both of this your internal customer and the external customer. But now I would like to understand a little bit for my stakeholder, that is, that cost of consumable, the billing part, these two areas actually is a very, very sensitive issue. One part I'm talking about communicating to the patient through the billing part, and the one part is the controlling cost, that is the bill of materials, because there is a lot many low cost corporates. We are overstretched with this lot many corporates, lower corporates, where there's a 50-60% that your cut that we'll have to make it, because from our general cost that is a 50-60% down. So in this very volatile situation, how you are managing? Are you taking help of the technology, creating some kind of a managing the consumable or control of the cost and billing part, because you will have to reduce the cost as well for the patients. So anything you are doing, any activity you are planning?
Sir, very. You said it was an easy question, but I think it is the hardest question at the panel today. Given this low-cost schemes and this little bit of oxymoron called cheap and affordable quality healthcare, all the hospitals are struggling. I think if you want to contain cost, it's a pure operational issue. And you have to be innovative. And as a lot of government schemes are now getting online, they're using technology for billing online and sometimes real time, and there are constraints of dates also when the same date billing have to happen. You will have to restructure your operations to meet both the things. I suggest dichotomy. I work very closely for the consumption part by creating virtual stores for each area, each department, and watching the consumption very closely. Not an easy thing to do. I have not totally solved this problem, but definitely using the hospital software to create captive or slave virtual stores is one way forward for understanding the consumption part. That's number one. Regarding billing, I think there are a lot of softwares which help you print the bill in a more understanding or understandable way. We have changed the printing part of a lot of our billing cover page and the content page in such a way that people understand that better, so the communication is better. But either which way, I think the effort has to be that somebody actually explains the structure of the bill. I'll give you one simple example. Some softwares give surgery, surgeon's fee, anesthetist, and assistant surgeon as a composite number. That becomes very large. So in our printout, we talk to our software vendor and we told them that please bill it separately. That's one way. But I would again say the most important part is to use technology in simplifying the printed part and explaining that to the patient upfront for better patient perception of your cost and costing. I hope I answered.
Yeah, that's right. That is how the technology can support us to controlling the cost and proper communication to the patient through proper system. And most of the time now we see that is the billing process also is changing very fast, because most of our the organizations, other organizations, government organizations and all, they are all becoming tech savvy now, and they are all uploading of the bills through this your system only. There is
rigid and very rigid.
Yes, very, very distinct. So this also will have to build in our system. That is one part. So I would like to quickly go to Partho. Partho, one thing that we would like to understand, one question, there's examples of your digitizations of support services in hospitals. You know, there are many support services in the hospitals so how you are making, can you give us some kind of an example of management of patient services request? Anything you are working, can we take some kind of a understanding from you how we can take it forward and your experience?
Yeah. The excellent area to discuss, because this is something typically we don't again cover much in our technology discussions. So any hospital would be spending around 20-25% of the overall cost to the support services, including security, housekeeping. If you look at this general duty attendant, the GDAs, they are one of the largest workforce. Sometimes their numbers are more than the nurses number in the hospitals. They typically are outsourced employees for most of the hospital, or some hospitals are still having them on the rolls. But irrespective of that, there is a huge headcount is sitting under this head of support services. And we don't typically do any digital enablement of these guys and try to save from there. If we look at if a hospital is spending 20% in that area, and even if we can save 20% of that 20%, that's a huge amount of savings for any hospitals. So what we thought that while the larger corporations are focusing on the clinical aspects of the hospitals, looking at EMR implementations in a completely different manner, as most of the speakers have explained, we thought, okay, let us focus on the area which is equally important, at the same time is not touched upon earlier. This is an opportunity and this is an option for a startup to look at. So we looked at multiple areas. We are now looking at options of how we can look at a service request of F&Bs. We look at a service request of all maintenance and the management. So suppose if you need to get a room temperature fixed, then how you will do it. So just a simple service request can get that done. And also we are looking at making a person available at the point of care to provide the services. The challenge is there are too many people in the hospital. But when we need something that time, we neither get the resources, means it's a, let's say somebody has to get a very normal ECG done. Then we find either the ECG machine not available or the ECG technician not available. Making both of them, and both of them are available in the hospital. We are very sure. We know that ECG machine is also available and technician is also available, but both of them are not available at the point of care when they need it. So we are working on AI-enabled workflow and optimization processes to ensure whenever there is a request is coming up, how both of them are available at this point of time. Yes, Soumitra.
Partho sir, I really want to compliment you. You always come out with a tangent of great importance. You have rightly said, it is not exactly so-called of delivery between patient and hospital staff, but between the two hospital staff itself. And you have rightly said, and I would suggest that a startup also look at things which we very carefully and very nicely sort of automated with no intervention was transport in and out, which is now reduced almost 60,000 calls a month in our hospitals, sir. Mm-hmm. I think there is very important role in dietetics being, service-based or just typing. Physiotherapists have similarly been automated, and it's very low-end tech. But this low-end tech leaves a very clear trail, and it can be very easily done. Why I just want to take this point, because in a previous panel discussion, I talked about the Hospicare software which we developed in the hospital. It took care of all these things which actually matter as much in terms of quality of service delivery as clinical care. Thank you. Just wanted to intervene on that.
Absolutely. Thank you very much. So you have done my job. So what is the more endorsement I can get than a person like you? Okay, so so we are working, and this is an opportunity, not working for multinationals anymore. Personally, for me now, we can decide that what we want to do is not that my boss decides what I want to do. So welcome. I'm sure all of you would have some point of time have aspirations. I have taken the risk. Hopefully it will pay off in some point of time. But I think we are looking at the time. Others also need to speak. But this is a very important area. Maybe in some point of time we should have some discussion only discussing about the automations of the support services. There is a lot of things to be done over there. As Soumitra rightly said, there are very low-hanging fruit, and there is no restrictions on the adoption problem. They will listen what you will tell. It's not like a doctor's issue that you have to listen to them. Here you give them something and they'll follow it, and the efficiency improvement will be experienced by the patients. They will really feel that they have entered a different era of service delivery altogether.
Yes. Thanks, Partho and Soumitra, both. That is it's real. See, this year and healthcare organizations actually face unprecedented challenges to improve quality in one way and improve access and eliminate waste And of course, in one area of concern only, or the goal is only how we can lower the cost. So that is the technology, we can adopt the technology to hold this, the journey we can complete. So that's very, very important area for discussion, and where we can take, technology can play a very, very vital role, technology can play. So I would like to, it's almost finished. Our part, the last question I would like to talk to ask Mr. Suresh Ramu. See, there is a two part that we can talk to you. There is a one part that is that the Prime Minister, our Prime Minister has announced that is a National Health Mission or National Digital Health Mission, NDHM. Where we are talking about, as per this program, it is going to be a complete digital health ecosystem that we need to create, and with personal health ID. That is a one part. So way forward. So how do you find how far this is possible or practical? That is one. And the second part also we would like to understand that is we are all talking about that your that your national, your health one part, and the other part is your we are talking about this is a mobile phone. That is the one major area of concern. So this is healthcare delivery through mobile phone. Is it a myth or fact? Is it possible? So this, if you can correlate these two parts.
Interesting questions. I think the mission that we have from the government perspective is a certainty, and I think we need to, as healthcare providers, we need to accept it and move forward. I think the dream and the vision of universal healthcare, I think, will happen. It's a question of how long it will take and how much allocation of funds, etc., will happen. So in that, the primary, I would say, is standardization of the way we manage our health records, the interchange of health records. And I think there are a lot of standards that are being developed, as we are aware. And I think that path will continue. The acceleration of access to healthcare in terms of either a variety of schemes, and with PMJI and a lot of the schemes, I think a large number of people will come under having access to healthcare, at least from an insurance perspective. Even if the amounts are small, I think the access, the basic access to healthcare will force healthcare institutions to comply to those standards and allow for interchange of data. As digitization goes forward in every aspect, I think healthcare records will also be required to be digitally available and demanded by the payers, including the government. And I think that is a definitive way forward that we must factor. It might take a few years simply because of the magnitude of this, but I think that is something I think we should take forward. Regarding the second question on mobility, I think, it is not an if question, in fact, about if we can deal with mobile phone or not, because the consumers are definitely not going to have computers or laptops, and even tablets or mobiles are basically going to be the future in terms of the way we are going to communicate. I think a single device to communicate and for interchange of data will be the way forward. Obviously, there are concerns about how the data is secure, who uses it, what are the platforms, because a large amount of telemedicine today, even in India or maybe a world over, is happening through WhatsApp. And I think the fact of the matter is that the data is not secure, and it is going through public, through channels that are not always as secure as you would like it to be. But that's the fact of the matter. As more standardization comes into play and the government maybe introduces platforms that allows for interchange of healthcare data, I think channels for exchange of information will also go through some of these standards. But it's an evolving path. I think there is a journey ahead. I think India is really galloping, I think, in terms of some of this and jumping some of the waves of usage of paper and decades of it. I think we are really accelerating in the way we are adopting technology, and I think we will see a lot of this in the next few years. Thank you.
Thank you, Mr. Ramu, and thanks everyone, because we are absolutely out of time, and we have discussed many aspects of digitizations in healthcare, and particularly from the end users point of view. Where we have considered is the patient experience, clinical areas, implementation of the technology, and also how we can mitigate the cost and how we can improve quality of treatment delivery model we can create. So all those points we have discussed. I think there are a couple of questions for the audience, but I think we can take it offline, because we'll ask Bengal Chamber, Angana, if you can forward it to the individual speaker, they can reply back. You can mail it so that the person that the question has raised, so we can give reply accordingly. So we'll not waste much of time. And thank you so much, all the speakers, Partho, this Mr. Divedi, I think Mr. Sika has left, and Shoumitro, and everyone. Thank you so much, Bengal Chamber. Thank you so much for the nice session. Thank you. Thank you all.
Thank you.
Thank you so much.
Thank you. So we will try to cover some of the questions in our next session, and we can always share with the speakers and connect them with the audience offline. And moving on, I would request the tech team at the chamber to relive the social media. And for the cloud streaming, the webcast, we will continue here now. There's no break in the webcast. So the next session is Smart Hospital Management Systems. It would be chaired by Mr. Sanjay Sen, who's the co-chairperson of IT Committee, the Bengal Chamber of Commerce and Industry. On, right? Thank you. So I would request Mr. Sanjay Sen to please take the session forward.
Thank you, Angana, and good evening, everyone. Am I audible?
You are.
Yes. Yep, thanks. So today's last session is on smart hospital. There's a very famous saying that today everything is smart around us, maybe we are not. So now we are talking of smart hospital. In the initial first sessions, we had a lot of discussions by Niti Aayog and others, where it was said that we have 1.3 billion people in India. Everybody have a unique ID. How do we reach healthcare to them? So the pandemic has determined that delivery can take different forms, be it education, be it healthcare, be it food, essential items, or be it caring for your parents also. The necessity is the mother of all invention, and it has forced us to look at the delivery. Now, another way that is coming is Industry 4.0. Industry 4.0 also, one of the areas of Industry 4.0 is to bring specialization to the door. So how we can achieve specialized skills across the net. Encompassing everything is how cost effective can we, because for India, cost is an important factor, and so are the world. While delivering these type of services, we need a governance, security, data security, and privacy framework too. So what are we talking about? We are talking of remote care. We are talking about data. what to do with the data. Can we predict? Can we predict the health of a person? Can we predict how the person will behave or his health will behave? Can we put AI on that? Can we have mobile health? Today, wearables are going to different limits. How well can we use them to generate data? And last but not the least, can we use blockchain to bind all this data? And beyond all is a quality healthcare. And we are talking about smart hospital. Does hospital means only between the four walls of the hospital or beyond that? To talk about all those things, we have a very eminent panel. We will start with Dr. Shrutin. He will tell us about smart hospitals and beyond. Dr. Shrutin, please.
Hi, everyone. I hope you can hear me. Am I audible? Okay.
Yeah, you are.
So I have prepared a set of slides. Maybe I could share my screen.
Yeah, you can.
Can you see my slides?
Yes. Yeah.
Yeah, thank you. Thanks, Dr. Sanjay, for the introduction. So all of us are aware about the challenges of an ineffective health system. We see this a lot in most of the emerging markets, including India. And what happens here is right from community care until the tertiary care, we find that, of course, there are problems of access to care. There are ineffective referral systems. The disease burden goes on changing based on the demographic profile of people. And the referral is mainly sometimes not timely. And all this increases the burden of disease and how we treat and address those issues. So what as Philips we try and do is we look at a continuum of care, starting right from the community care until the tertiary care. And we look at kind of digitizing the pathway. So if we could digitize a pathway right from community to primary, secondary, and tertiary care, we could mainly look at and solve some of the issues that we see with ineffective healthcare delivery. And before our session, a lot of people talked about how digitization can help and how smart hospitals or Hospital 4.0, an analog of Industry 4.0, is effective in improving operational efficiency. So same way, digitizing the backbone and digitizing specific care pathways, like say, for example, can we digitize an antenatal care pathway, for example, or can we digitize a tuberculosis care pathway or a diabetic care pathway right from community to tertiary care, so that we can not only look at preventive care, we can look at effective referrals, we look at secondary prevention if possible, and so on. Of course, because of market forces, this is seen globally. There is a rise of healthcare delivery costs. A speaker before me addressed this and how their hospital tries to solve it. Then we look at aging population, including in India. There are some cities like Mysore, for example, very close to Bangalore, where I stay. There is a significant number of old people staying alone at home, and their children are abroad. And healthcare consumerism, it's a big issue. Issue in the sense, young people, they demand healthcare as if it is some kind of an offering, just like Amazon or something else like that. And these trends actually have resulted in the hospitals, put pressure on the hospitals to become smart. And what we do as Philips is we try to partner with hospitals these days and address the quadruple aim. And what happens is we partner with hospitals in a way that we have skin in the game along with the hospital to ensure better health outcomes, improve patient experience, improve staff experience, and lower cost of care. It's exactly the problems that the speakers or the panel before us have addressed. To go to the next slide, what we see is that hospitals in India or even in the emerging markets, they are in various stages or levels of maturity. From many of them do have an electronic medical health record system, but they may not necessarily be smart. And there are some hospitals which have integrated some of their processes, have tried to use AI in certain departments, as you may have seen the speakers before me and heard them. So these are probably reaching a stage of maturity. And of course, there are hospitals which are completely aligned with the quadruple aim and using a digital backbone to the best possible extent. And those hospitals are what we could call as smart hospitals. And of course, the patient journey starts not in the hospital, but it starts right from the community. So we call it within Philips as the healthcare continuum. And we look at almost all aspects starting from healthy living, prevention, diagnosis, treatment, and home care. So we have solutions, for example, for pre-hospitalization, hospitalization, post-hospitalization care, and so on. And we partner, as I mentioned, with hospitals to improve operational efficiency, clinical efficiency, patient centricity, for example. And these are some of the areas that we partner with hospital on, especially radiology, that is our strength, cardiology, intensive care units, emergency department, EDs, operating rooms, outpatient and general surgery, and pharmacies. So these are areas that we see we have maximum impact when it comes to having an AI, artificial intelligence solution, along with making these systems and which can improve operational efficiencies in these particular departments. Of course, pre-hospitalization, we have several, we partner with hospitals where we have developed many times virtual assistant for them, which is which patients can actually chat via a chatbot, record their vital signs, then get in touch with the hospital, and then walk in for an appointment. And appointment scheduling is also a part of that. What we do is, so these are various levels of maturity when it comes to dashboards. So with the post-COVID and even in the COVID, we see that the government has actually very effectively utilized dashboards which tell us, okay, what is the number of COVID cases, how many are they increasing, those people who are treated, and so on. So hospitals in the, I would say in the pre-COVID era, they were using dashboards, but mainly developed by their own IT department. Sometime maybe in the last decade, they started having vendor partnerships or gave contracts to vendors. But what we are looking as Philips going further post-COVID is that we partner with hospitals where we have skin in the game, where Philips not only partners with hospital to improve efficiency, but also share the risk. So ensure and promise hospitals that we would improve patient outcomes, for example. And of course, these are some of the areas where we use artificial intelligence in a very big way. One of them is intelligent imaging, remote patient monitoring, medication management, and communication, like some people talked about before me. So these are some of the areas. So I will not go into them. Maybe in the question answer session I could answer. I just wanted to give an overview about what we do. Post-hospitalization is a very big area where we are interested. Like telehealth is a very significant area where we partner with hospitals in delivering post-operative care and care management at home. So what we do essentially at Philips is we ensure that our partners become smart, we ensure that the partners, we partner with hospitals, and we ensure patient centricity. And we basically have a digitized pathway right from the community via the primary and secondary care center to the hospital and back to the home. So that's how we cover the entire care continuum. And that brings me to the end of the talk. It sets a sort of cadence to our discussion, and I'm looking forward to it very eagerly. Thanks for this. I would be happy to take any questions.
Thanks, Dr. Shruthen. So basically what you are saying that smart hospital is a journey and it's not a destination, and there should be a strategy and a roadmap to achieve those. And that's what...
Yeah, so typically what... Yeah, sorry. So that is typically what we have seen when we partner with hospitals, that hospitals are in different stages of maturity globally. And what we see is we first assess the level of maturity of the hospital, and then we partner with them having a skin in the game. So we actually talk about sharing revenues with them, and we ensure that the hospital revenues also increase. So that is what the game we have, and that's the reason why I talked about different levels of maturity. And typically, what we see is that the hospitals do go through these stages of evolution until they become smart.
Okay, thank you, Dr. Shruthen. We'll come back to you. Now,
Sure.
beyond the four walls of the hospital, to discuss on this and more, over to you, Jimmy.
I trust you can hear me.
No, not clear.
Similar to me a bit. Better then. Still not audible?
No, you're not. There's an echo coming, Jimmy.
I think there's a loose connection with your microphone. We can't hear you now.
I've been trying to fix this.
Yeah, it's fine. You're audible.
Great. Thanks a ton. So what I would do is also like to share, I would say, one or two key slides here, and let me know if you can see it. And rather building up of just from where Dr. Ullman left a couple of minutes back. And the focus of the discussion over the next 2-3 slides, I would rather not spend a lot on the slides, but more on the discussion here is rather say the care which is provided to patients beyond the four walls of the hospitals. And the view is definitely when we as talking about a pharma company typically look at patient being at the center of everything, and overall taking the support of the entire ecosystem, which is not only hospitals but also the care places that are there, the homes which are there, where they are staying, also the various devices which are available from the different players, but to see how we can provide a better experience to the patient. Now, from a pharma company's point of view, I would say there are two things which we are focusing on primarily, and some of that also spoken by a few speakers before. Dr. Ullman also mentioned regarding improving patient outcomes on one hand, but also I would say one of the topics we need to look at is having a more flexible supply chain to cater to the needs of the patients. I think these two are primary, I would say, top of the mind for any of the pharma companies. And now with respect to the first one, I would just quickly share one more slide, not to again get into the details here, which some of my, I would say, panelists also spoke about a couple of minutes back. But here I would focus on one or two aspects. So one is, the first one is talking about the emotional / psychological aspect, where where there is now the pharma companies and more so Bayer also working more and more with digital therapeutics companies globally to improve experience of the patient. It's by increasing engagement. It's not only about prescribing what kind of medication along with the HCPs, but also to provide, I would say, disease management, providing them enough information if they are, for example, depressed, if, example, they are nauseating, if, for example, they are under immense pain. So multiple gamifications are also available to not only focus on the physiological needs, but also on the psychological needs of the patient. So this is, I would say, outside the hospital area, just to give a better experience to the patient. And all this is possible today based on the data available coming from the patients and coming from the network of people, network of patients suffering from similar diseases. The second and the third one talk about more the physiological aspects, which is improving clinical outcomes. This is again based on more and more data. Effectively, we start off with standard protocols in the hospitals, but then with the help of more and more data, you can improve the protocols you see are much more customized in today's world. So this is where I would say, again, the digital therapeutics come into place. The third one, human error is definitely one of the topics which can be avoided. I know the entire I would say healthcare system is under tremendous stress, but if there is an opportunity to further reduce human error and also increase medication, adherence to medication, I think this is again with the help of digital therapeutics, which is primarily in most cases an application, is what we are trying to achieve outside the smart hospital, I would say the four walls of a hospital, and include it as an extension of a smart hospital system. The other benefits, again, I would also like to talk about here, and this is allied benefits for very, very focused on the pharma companies. It's less to do with patients, but definitely these are the byproducts of the overall digital therapeutics area. Number one, there is definitely more data available from the patient, so which helps in drug development and drug discovery for next generation products, because you see how things are progressing. At times it works, at times it doesn't work to the extent that we would like to do. Now with as Mr. Sen mentioned a couple of minutes back, necessity is the mother of invention, and we also realized that while our sales force couldn't go and reach the HCPs in most of the cases, interestingly, most of the HCPs very quickly adapted to the more auto or digital ways of communicating. Mr. Dwivedi also spoke about it a couple of minutes back. And if we see that there is a lot of synergy that we are providing now with our sales force, they don't need to be mapped per district, per doctor, almost to that level, even going time and again to the doctor. So all this can be made available because of the smart hospitals. And this is, again, I would say, extension of what is available beyond the typical hospital care. And last but not the least, it's improving access to the HCPs, because many a times this is typically an application where the patients, the caregivers, and the pharma companies are connected. So it also improves the communication of the HCP just beyond regular periodic discussion. So in a nutshell, if I summarize, with the help of smart hospital management systems, there is definitely more benefits for the patient, and also I would say overall for the ecosystem. The one thing which I didn't include here, which again is very, very close to my heart, and it also was raised a couple of minutes back regarding the overall cost of care. And this, I would say, with the help of the system, is also is improving. How it happens? I would say now with the help of digital therapeutics, the number of days for patient in a hospital, in a physical hospital, can be reduced, can be minimized based on the risk, obviously, and also based on the treatment. And this will also reduce the overall hospital cost. Secondly, when it comes to specifically to pharmaceutical dosage, it's not one size fits all. It's much more customized. Many a times, I would say, lesser dosage, and that's why I would say overall cost of care is also reducing. So in a nutshell, I would say it's a win-win situation for everyone, as far as and when we look at from a pharmaceutical company's point of view. I would draw your attention also to how the supply chain has changed, because I would skip the other slides because we can go again more and more into the details, but I would rather focus on the moot point out here. If you look at the supply chain traditionally, it's been based on, again, pharma companies' view. The supply chain has been more push-based, saying do the product development, get it through the distribution, put it into the pharmacies and or to the patient. So it's a very push-based supply chain. Interestingly, now with the change, with again patient being at the center and also many a times more involved in the decision making, all of a sudden you see patient is coming at the beginning. So now it's not a push-based, but rather a pull-based supply chain. And if I just kind of summarize, there are 3-4 findings when I look at supply chain, because more and more there will be need for, I would say, more flexible supply chain, primarily for 4 differences that I see from what is today and what we would see in the next couple of years. My best guess would be in the next 2 to 3 years. So current treatment mechanism across oncology, cardiovascular, diabetes, most of this is more curative, and in the future we will see both curative as well as preventive. Secondly, when it comes to medicine delivery, and many a times involving cold chain, it's very much provided to the warehouse or the hospitals. And now the pharma companies have started thinking about providing it all the way to the home care or the homes of the patients. We spoke about it even in the previous discussion regarding more standardized protocols, and now with the help of data, we would see more and more customized protocols, which would also impact the demand of the pharmaceutical products. And I spoke about it a few minutes back regarding companies thinking more push-based supply chain, saying get the product, get it into the market, and now thinking patient at the beginning and customizing it, I would say, along the way. And what is important again for the pharmaceutical companies is to have end-to-end view on the supply chain. So connecting all the way from the point of sale, where the product is getting delivered to the patient, all the way back to the suppliers for API, excipients, etc., etc. I'll pause here because I would rather even open to questions later on. But in a nutshell, that in a nutshell covers the benefits that we see of the ecosystem, not only within the 4 walls of the hospital, but outside the 4 walls. And on the other hand, how the supply chain needs to be adapted to ensure that we are providing that level of care to the patients.
So, Jimmy, what you are saying is that a couple of things. One is gamification, which is quite new, okay, more to enhance experience in psychological way. Digital therapeutics, which is, again, combining everything. Then logistics, medicine delivery at doorstep. In fact, today we have a lot of apps coming up where they are gearing up, where can do those things. And another important thing you said is that usage of data for customized medicines. That's different actually. How do you really customize for a particular patient? Is it the dosage? And how do you use data? How can you use patient data as a pharmaceutical company and others? So those things, those questions needs to be answered in the new era of digital smart hospital systems.
Mm-hmm.
We will go to Dr. Pankaj Gupta to address some of these issues of data governance and others. Dr. Gupta, please. Dr. Gupta, you're mute. Yeah.
Thank you for having me here today evening. And after the such beautiful presentations, I thought I'll bring a few slides to the table for the discussion. I have done a lot of digital health transformations globally at a hospital level, at a group of hospital level. I've created smart hospitals or paperless, filmless hospitals as they were called at one point in time, at a single hospital, group of hospitals, regional level, and at country level. My current role is trying to do it at a country level. And there is a whole lot of stuff that we are trying to do. So I thought I will have a little bit of a discussion today on what is going on at the country level, which involves a single hospital. It involves groups, regions, and what is happening outside the hospital, what is happening in the community level, and all that. So let's look at what are the levers of change here. The first lever of change I will talk about is a financial lever, or it is the health insurance side. So there's a massive change that is coming in with Ayushman Bharat coming in. And before Ayushman Bharat, the health insurance coverage in this country on the private health insurance was only 3%. And on the public health insurance, even if you include all the government schemes, about 10%, so about 13%. Now with Ayushman Bharat coming in, we are crossing the 50% mark. We are going to about 53% of the population that is covered, and that gives a huge lever of change. Now if the insurance starts asking the claim in a standard format, in an e-claim format, the entire market has to turn around and support it, because their payment depends on it. And in all the research that we have done, went and spoken to all the CXOs of hospitals, all the smart hospitals and not so smart hospitals, all of them said we will make changes if that is really required to be done, because the turnaround time is faster. If the turnaround time is faster, the cash in hand and the working capital improves, and they would definitely want to have that as getting it done. So that's a huge lever of change that is coming in from the government side, using the health insurance and asking for claims in a standard format, and we call it the e-claims. The second one is what happened about a year back. We were hit by a pandemic. We never thought that something like this will happen. And when it happened, we wanted the data coming from different sources, different labs, different hospitals, different clinics, to come together to be analyzed for epidemiological analysis. We were not able to do it because everyone was storing the data in a different format. Everyone was doing their own thing. And there had to be intermediary quick fix mechanisms that had to be put in place by the government, by the private sector, to bring the data together so that we could make sense out of the pandemic that hit us. Now, that was a huge lever of change. The government woke up and said, well, this time it happened. We make sure that next time it doesn't happen. And that is when all the standard work that was already going on in the background was brought to the fore, and the National Digital Health Mission came into being. The third lever of change is the e-governance lever. E-governance is when you layer services, healthcare services, on top of the digital platform. So Jan Dhan Aadhaar Mobile is already there. In addition to that, now what the digital backbone that is coming up based on the National Digital Health Blueprint, you can layer all the e-health services. The current one which is being rolled out are vaccines. And similarly, you can have telemedicine, you can have e-pharmacy, you can have, disease-based programs. All of them can be sort of rolled out on the rails that are laid down by the digital health. All of this digital health transformation for the new normal, as we call it, is going to be based on digital health standards. The National Digital Health Blueprint has already been published, and that carried forward the work that in the past on EHR standards, the metadata standards, the registries and things like that. Let's go a little deeper into this. Why was this really required? Because, of course, the pandemic hit us now, but all the digital health work has been going on in terms of standards for a long time. But why? It happened because, the vertical programs wrote their IT systems in their own way, and each of the vertical program, which is the mother and child, of course, is there, but then you have the NACO and you have the tuberculosis program and so many others. So each one of them do not talk to each other. Now, if there is a child that is born which has a low birth weight and the mother had suffered tuberculosis in the past, there is no way you can trace it. because each of the data element, each of the data pieces is in a different system and there is no traceability. Now, in 2014, there were two committees that were created, an EHR standards committee and a metadata standards committee, 2013-14 timeframe. And both of them wrote the standards and said, this has to be institutionalized. However, our entire bureaucratic process, our own, process of going through consultations and public consultations and everything took us 5 years, and it was notified in 2018, just before the launch of the Ayushman Bharat in 2018-19. And then after that, the stage was set and the National Digital Health Blueprint came in and provided the architecture. It is the, digital health architecture, how you use these standards. Having the standards is one thing, but how do you apply it? So the Digital India framework was used. And then the architecture was given that, these are the architecture principles based on which you will create applications at a single hospital level, at a regional level, or at a much larger level. Let me delve a little bit deeper. We wrote a book called Health System for New India with Niti Aayog. The chapter 5 is a digital health chapter, and I am a co-author of that. In this one, we wrote very clearly as to how the digital health transformation needs to happen. And we introduced the concept of e-objects, where the transformation needs to happen between, so if you want to send any data between provider to provider or provider to pair, the minimum set of data elements that are required to be sent, we designed it and presented it. The concept was presented in the Niti Aayog book, and then later on, we detailed it out as Access Health. And Access Health Digital is a focused group that has been working on it ever since. We have brought it out for the provider space as well as for the payer space. For the payer space, we've been working very closely with the government to get it through. For the provider space, we run a provider working group where we brought in all the large providers from the private sector as well as from the government, and try to bring consensus on these e-objects. Let me go and talk a little bit about what these e-objects are. On the payer side, e-claims is one of the e-objects which asks for claims in a standard format. Why does it need a standard format? IRDA also had a standard format, but IRDA standard format was not machine readable. Now what we are saying is it should be machine readable. Human intervention. Now, to make it machine readable, the diagnosis has to be in a standard called ICD-10. You have to have the procedures in SNOMED CT. You need to have all the lab orders and the investigations in Loing standards. The drug orders have to be in a national drug index, and so on and so forth. In addition to that, all the data elements have to be based on metadata standards, all the demographics have to be based on the metadata standards, and so on and so forth. On the provider side, a similar construct is there, that if you want to send out an e-prescription, a standard e-prescription, then the e-prescription has to be based on e-prescription e-object. And so that the receiving side can automatically read it without any human intervention. Any e-pharmacy should be able to use it. If you want to do a telemedicine consult, then the e-encounter form needs to come out, which will carry all the notes and the prescription, whatever has been given by the doctor, because the doctor may have said that refer the patient to so-and-so higher center. The higher center needs to receive it in an electronic format and be able to process it without any human intervention. Similarly, when a patient is getting discharged from a higher center, whether it is secondary care or a tertiary care, we have e-discharge summary so that it carries the minimal information that is required at the time of discharge in an electronic format to be processed later. It can be stored in a DigiLocker, or it can be sent to a insurance, which is coupled with e-claims. So, this is the entire framework that has been put in place. It is being rolled out. And as we see, we are not talking about making one hospital smart any longer. We are talking about making the entire country smart now. And in addition to that, we have done one more thing, and that is we've come out with minimum viable product definition for the applications. So if you have to build an application, these are the minimum set of modules minimum set of functionality that you need to have for a primary care, secondary care, or a tertiary care. What we did was we proposed that all of this should be done based on microservices. Microservices is the latest digital technology on which all your OTT platforms, all your Netflix and Amazon, they are based. It is so nimble that it will work on any platform, any hardware. It will work on your mobile, it will work on your laptop, it will work on your TV, it will work on even a larger hardware. And it requires a very small footprint to work. And any network will be able to support it. So we designed this and we put it in open source. We run an open source community in which 40 startups are working with us, implementing all of this. And we have told them that if you use these constructs, then whatever you build out of it, you have to bring it back and pour it into the open source community. And this open source community is beginning to thrive. So these are our small little changes that we are trying to make. We are an NGO working with the government, and hopefully we'll be able to contribute a little bit in transforming this huge country from where it is to a more smarter country. I will rest my case over here, and then we can take it forward in terms of discussions. Thank you so much.
Thanks, Dr. Gupta. Really, this is actually setting the backbone for the development. If you see creating the metadata, creating the objects, all those will set the foundation on which things can be built. Now, you also mentioned you're working with 40 startups to build on these type of open source so that people can be used, and also your strategy of micro coding is also very, there's an ideal way, or there's the only way to, if we really want to transform, and what we will, I am sure as a country we will, we need the help of startups. Startups will play a key role, in these transformations. While the big daddies will have their own places, the startups will have. In BCCI, we also have a program where we encourage startups, and there has been quite a success in that. One of the startups identified is Rajiv and his team. So we will try to present that what are the things that they are doing and what are the way they are trying to enable this transformation. Rajiv, over to you.
Thank you, Sanjay. Good evening, everyone. I represent Arogya Medisub Solution. We are a startup based out of Tech Incubation Center of BCCI, and what we have developed is solutions for rural India, connecting them to the hospitals, making the accessibility and affordability to the healthcare. We have developed a small analyzer. This is a blood and urine analyzer, as you see on the screen. This analyzer can assess around 25 parameters, 15 in blood and 10 in urine. So, and this we have integrated, along with this, we have integrated a digital stethoscope, which can transmit the auscultation, like the heart and lung sound of the patients to the doctor remotely. And as well as we have a kitchen shaped ECG machine, which can perform 12-lead ECG. And it can be performed by any health worker in a remote location. So using these tools, we have, I'll come to a presentation. I'll share my screen. So using these tools, we have Is the screen visible?
Yes, or in a presentation mode.
So using these tools, what we have done is we have connected very remote located places with the doctors in cities or in the cities, and thereby patients in the remote locations can now avail the advices of the doctors, while doctors can advise them based on the evidences that are collected through the various devices that we have placed in those centers. So we, as of now, we are working at 10 locations, and while the doctors are spread across the world, means few doctors are even catering from US to the patients as remote as in villages of Arunachal Pradesh. So we are now having spokes in these states and hubs also created in each location, each states, and they are then like connected with the doctors. So what like in smart hospital scenario, what we were envisaging is like that patients cannot come to the hospitals or like have to make quite a lot of journey to come to the hospitals or setups which are mostly in the urban localities. So they can be tapped and like they can be reached by the hospitals in their own villages and catered to, and only when there is a necessity of them to be referred to the hospitals, they can be transferred to the hospitals. So thereby the entire the delivery system of medicine becomes much accessible and affordable. So these are certain, these are the ways that we do. Like in each center, these devices are located in the outreach centers. And through these devices, the A&M nurses, they can cater to, like they can even do the blood test using this device out there, and collect all like auscultation, patient auscultation, and the ECG, BP, and everything, and register them on our telehealth platform. And the doctors in the hospital scenario or the urban centers, they can access those and write e-prescription, which is again transmitted back to these centers. The system is HIPAA compliant, and we have tried to keep all the security protocols, maintaining everything. So by this, what we have seen is it is improving the speed of execution, reducing the monitoring time, reducing the time for compliance, and reducing the operating cost, thereby making it medicine more accessible and affordable. So this is a portal that we use, the telehealth portal, where we have a hub and spoke model, and doctors can access it through the hub user access. Hello? Am I audible?
Yes.
Yeah. So the doctors can use it from the like hub user module, while the nurses and the NM ASHA workers, they use the spoke user module and cater to the patient in their villages. So this is a system which can be like, it's very easily lightweight. Like the entire thing, all these devices that you are seeing can be packed in a backpack and be carried, and the total weight is less than around 2 kilos. So it can be easily taken like on a cycle ride or a bike and taken to very remote locations. Even by walking also, some locations are catered. It's very easy to use by the, even like since the interfaces are more or less like a mobile phone. So the nurses or the local people, they find it quite easy to use them. And all of the devices works on its inbuilt battery. So the requirement of power at the stations are not that much. We train the people, we provide online supports, we supply the devices, and then we connect the hospitals with their outreach centers and let them operate on their own. That's how we the model that we follow and we are serving. So these are certain glimpses from the different clinics that are being run. So We have our endeavors in Northeast, that is Arunachal Pradesh, recently won the District National Digital Award 2020 Gold. We got awarded from Bengal government in Bengalathon 2018, from where our journey started. These are the different clients and partnerships that we are currently having. So I'll leave that out here and I'll be open for questions, and if any queries are there, I'll be happy to answer.
Excellent, Rajiv, excellent.
Thank you.
Now we can open the floor for questions and discussions. Angana?
And there were some questions which I posted in the chat, which will come from the audience. You may please also refer to them. Like patient data storage is better in local servers or cloud server?
Dr. Gupta, one of the questions that was asked is that do we store that patient's data locally or in the cloud? Because as we know that both have its advantages and disadvantages, and if we are into the cloud, what are the do's and don'ts that we need to follow?
The National Digital Health Blueprint, as I mentioned, is cloud first, mobile first. That is the two basic principles that are laid out in the blueprint. So gone are the days when you used to design for the desktop. Gone are the days when you used to design for a single application, which is a local install. We now need to design, and that is a demand that is being put by the National Digital Health Blueprint, that please design your application which is cloud first and mobile first. Of course, it can run on any other platform other than mobile, but you must design it. The first design principle is that it has to be running on the mobile. Mobile is not an afterthought. Similarly, cloud is not an afterthought. It has to be designed for cloud, and it can of course run on local install. Now, given that, there's another principle that is laid out in National Digital Health Blueprint, and that is a federated architecture. The federated architecture tells you that you need to have your application data stored locally and shared nationally. So what that means is, without the cloud, you just cannot do it. You have to have a cloud interface. You need to have the cloud built in. But also you need to have the privacy and security principles built in, so that more than privacy, I would stress on security. The data security is the most important thing. You do not want the data to be accessed by people who do not have access, or who should not have access to it. And these are small, simple things. How to do it is all written in the blueprint. If somebody goes through it, all the hows are written in that.
Thank you,
Thanks,
sir.
Dr. Another question is for Rajiv. Rajiv, what are the plans of scaling this up? Rajiv?
Next. Rajiv is there. Rajiv, can you hear? Somehow it's not responding, but he is showing on the. The other question is, technology's role in COVID-19 vaccine transportation. Like, would you like to address this? It's like, I think it might be very broad, but up to the discretion of the chairperson.
Jimmy, will you like to take it?
I'll try to give it based on the other broader experience as far as distribution is concerned. So definitely we see two I would say, trends over there. As I spoke a little bit about the flexible supply chain, I think more and more we have tried moving towards that, and with the help of third-party players. So primarily, if you look at the companies like, I'll just give one example. DHL is now investing heavily because now they even have third-party, they even have GMP, I would say, certifications in a few areas. So which I would say typically one pharma company, it's very, very difficult to do. So you see now we're extending more and more with the support of the third-party partners. So I know Maersk is also doing, DHL is also doing. So that's number one. And so using that distribution. Now, as far as technology is concerned, I would say, again, this is end-to-end connectivity of data. If you see, there are even now paper-based labels which are used for tracking. So the world has moved to a paper-based label. So even the SIM card, which is as thin as a paper, you just put it on the vaccine more for traceability. That is coming handy to understand the exact movement and to even kind of see how fast it is going. Now, so on the distribution side, again, we use more and more of these third-party partners, but from a technology point of view to track and trace, this is the kind of technology which we are using. If I would like to qualify that, we are still far away, I would say, to the extent where we want to be, because this is more a nascent technology. The backbone and all, which Dr. Gupta mentioned earlier, is still to be developed. I would say we are still a couple of years away from having that end-to-end view. But so if I would rest my case on that, I would say there's still some progress going on, but in the current situation, it's one step at a time.
It's just the beginning.
This is just the beginning.
Dr. Shrutin, we'd like to understand that how much time typically in a journey from a brick and mortar hospital to a smart hospital transition typically takes. And especially, is it a chain that rolls out, or it is hospital by hospital that do it? What are typical models that you recommend?
Yeah, that's a difficult question to answer, but let me attempt it. So what we have done is, we have looked at diseases as a digitization of a disease backbone. Like, say, for example, we started with mother and child care, mainly antenatal care. So we looked at digitizing the entire pathway, right from infertility care until until a lady becomes pregnant, then all the 3 trimesters of pregnancy, then labor and delivery, and then post-natal care until the child is 2 years of age. So we digitized the entire care pathway. We tried doing it first in Indonesia, then we did it in India in some centers, and then we did it in Africa. So what we have, after gaining those experiences over, I would say, the last 15 years, what we have done is maybe over the last 5 years, we started entering into more of tertiary care hospitals, and then partnering with them for revenue generation and for having skin in the game was a big, I would say, a risk that was taken by the company in general, because we were mainly vendors initially, but to partner with a company, with a provider, and then to understand their problems thoroughly, look at how we can optimize their operations, look at improving clinical efficiency. So that itself would take some time. So what we have is, we have a few successes, and the journey has become even more stronger. But to answer your question in a nutshell, it typically would take at least 2 to 3 years of rigorously working with a partner, and then understanding one particular clinical pathway, and then to make that pathway smart. So that is what I have and my team has learned over our experiences with working with partners.
Oh, really, that was really, I never thought of it actually. This is a way to go. Thanks for enlightening us, Dr. Shrutan.
Thank you.
Yeah. Dr. Gupta, the question is that we are a 1.3 billion people country carrying healthcare to the remote corner of from Kashmir to Kanyakumari is a daunting task. What are the 2-3 things that we all of us should do in order to achieve that? Because I believe that each of us has some responsibility from a social aspect or the way we do it, what we need to do.
Sure. It is definitely a daunting task. Now, to really adopt the change that is coming, government can do only so much. Government has done its bit this time. You know, every time while I was working in the private sector, it was our, best hobby to blame the government that they don't do it. But this time around, the government has done their bit. It is for the private sector to stand up. It is for the common man to stand up and adopt it now. Now, it is time to go and pick up those pieces. Of course, there will be flaws initially. Of course, it will take time to stabilize. But then, give it time. Give it time to stabilize. Whatever has been provided, use it. Unless you use it, the data will not become available to get stabilized. If you shun it in the beginning, then it's a non-starter. This is every time that I say that, the 40 startups that work with me, when the first time I gave a call, please come and join me, they said, Saab, ye India hai, ye hoga kya? Aap bol rahe ho, lekin theek hai, lekin hoga kya? Today when I ask them, I don't pay them even a single penny. They're with me standing firmly and implementing all that. I ask them why. Because we do this regular, customer feedback and all the feedbacks from our startups. I asked them why. Why are you still standing? They said, "Saab, hamara business to pata nahi kahan chala gaya." Matlab, what the government rolls out, we are already there. We are ready. We are already, sort of energized, and we are putting all the building blocks already in place. So, it is for now the individual to stand up and say, me first, can I get it? So those are the only 2 things that I would like to say, that government has done its bit. It's for now us to stand up and adopt it.
Rajiv, a question to you. What's the plan of scaling this up?
Okay, so what we are doing is we are already got into the primary segment, like primary initial rollouts. Now we are trying to get into the government programs, outreach centers with the hospitals. That's what we are building. We have also started approaching a lot of MNCs with their different programs, like CSR programs or the sustainable growth programs. And even we have reached few overseas clients in Africa, where we are doing certain installations. So that's how we are expanding now.
Okay. Angana, if there are no more questions, I would like to thank each and every participant from the bottom of my heart. It was really, really an enlightening session for me. And I am sure all those people who are listening to us. Okay, and also health is wealth. And I think by this we are creating wealth for the country at large. And I wish this goes on and life goes on. Thank you very much for joining this session on behalf of BCCL. Thank you very much.
Thank you.
Thank you, everybody.
Thank you.
Thank you.
Thank you. Good night.
Tomorrow's sessions are on Korea's K-Quarantine, ICT Solution 2020 and panel discussion on role of technology in care, caution, prevention in normal life, and technology adoption in healthcare delivery in cardiovascular and immunology and rheumatology. It will start from 3:45 p.m. IST, so we look forward to having you with us. Thank you.
Thank you.